Hello and welcome. I'm Judy Burkhart, National Director of the Nursing Programs for Kaplan. And today we're going to be talking about physiological integrity and the subject of basic care and comfort. Let's begin. The first thing that we're going to discuss is mobility and immobility. And there's several things about immobility and mobility that you need to know, and let's go over those quickly now. First of all, I'm going to be discussing some terminology, and I will define it as we go, and it's important that you remember what these definitions are because they will be used in questions. The second thing I'm going to be talking about are transfer techniques. Because the exam is about safe and effective care, it's important that you know how to safely transfer a patient from bed to chair, from chair to standing. Another thing we're going to be talking about are ADLs, or activities of daily living, and exercise. And we're also going to be talking about a very important topic, which are complications of immobility. And lastly, we're going to talk a little bit about how to use assistive devices. Let's begin with some terminology. The first term that I'll examine for you is lumbar lordosis. Lumbar lordosis is a concavity in the lumbar region. Some people call it swayback. Second term I'll define for you is kyphosis. Kyphosis is a convexity in the thoracic region. Some people call these humpback. The third term is scoliosis. Now with scoliosis you have a lateral curvature of the vertebral column, or an S type of curvature. Another term I will define for you is flexion. Remember, flexion is where you decrease the angle of a joint. For example, when you bend your arm, you are flexing your arm. The next term is extension. With extension, you increase the angle of a joint. For example, if my arm is bent and I straighten it, I have extended my arm. I've increased the angle of the joint. Let's go on with some additional terminology. Hyperextension. When you hyperextend something, you excessively increase the angle of the joint. For example, if my arm was extended and then I pushed it way far back, that would be hyperextension. Now the next term is very important that you remember this one because it's used a lot in positioning after surgery. For example, and this is abduction, A-B-D-U-C-T-I-O-N. Abduction is where you move away from midline. And the easiest way to remember abduction is if someone is kidnapped, they're abducted, they're taken away. So if you think of that when you see this term, it's a very easy way to remember it, because I'm going to contrast it with the next term, which is adduction, A-D-D-U-C-T-I-O-N. Now with adduction, you move toward the midline. And the way I remember this is I'm adding, A-D-D-I-N-G, adding to the midline. Again, you need to remember the difference between abduction, which is away, and adduction, which is toward. The last term we'll talk about here is rotation. When you rotate something, you move it around a central axis. For example, when you spin, you rotate around. Okay, let's talk about exercise. The Nclex talks about wellness issues in addition to disease processes. And one of the things to help with wellness is exercise. And why do we exercise? Well, one important reason is that it maintains joint mobility and function. And this is an important concept with patients that are immobile. The second result of exercise is that it increases muscle strength. Again, if you see weightlifters and bodybuilders, you can see that their exercise has been very effective. The third result of exercise is that it maintains circulation and ventilation. This is critically important with the immobile patient, and this is why we do, for example, range of motion exercises with patients that are on bed rest. Another result of exercise is that it increases appetite and maintains elimination. Patients don't get constipation if they have a good regime of exercise. And the last result of exercise, and this is why the health clubs across the United States are full, is that it increases metabolic rate. And for many people, it helps them maintain their weight. So that's a little bit about what exercise does. Let's talk a little about transfers. Again, remember, on the Nclex exam, you need to know how to safely and effectively move a patient from one place to another. The first transfer we're going to talk about is how to help a patient sit on the side of the bed. Okay, the nurse will, number one, place his or her hands under the patient or client's shoulder. You will have the client push his or her elbow into the bed. So they're going to assist you, help them to sit on the side of the bed. And then the third step is you're going to lift the client's shoulders and swing the client's leg over the side of the bed. So again, the nurse puts the hand under the client's shoulders. You have the client push the elbow into the bed to assist you, getting them upright, and then you lift the shoulders and swing the legs in a fluid motion to the side. Then your patient should successfully and safely be sitting on the side of the bed. Let's talk about how to get a client to stand, or how to effectively do a transfer to stand. We have the client, picture this, sitting on the side of the bed. Now we're going to help them stand. Well, the first thing we'll do is grasp each side of the client's rib cage. So the nurse is facing the client and grasping the client's rib cage, not in a death grip, but firmly. The next thing the nurse will do is push the nurse's knee against the client's knee. This is a safety precaution to make sure that the client's knees don't buckle. The next thing the nurse will do is rock the client toward her or him to get into a standing position. And then once the client is standing, you will pivot them to sit them in the chair. Now, I didn't mention it, but before we start this whole thing, we want to make sure and have our equipment in place. So we want the chair on the side close to the bed so the client wouldn't have to walk across the room to sit into the chair. So again, you grasp the rib cage, you push your knee against their knee, you rock them to a standing position, you pivot them, and then you help them or ease them down into a chair. And one thing that's important to remember, and Nclex frequently tests it, is, well, what side of the body do you move toward? Always remember you work from strength. You want to place, for example, the chair on the client's good side. You want to move toward the good side because it's always easier for the client to drag the weak side along. So work toward people's strengths. If you kind of remember that concept, it will help you know which way do I move, where do I put the chair, always on the good side. Now let's get our patient or our client out of bed. If you're transferring a client out of bed, again, first key component is you will move the client toward their strong side. Again, it's easier for them to pull their weak side. And that means, as I said, you will place the chair on the client's strong side. So again, you're working with strength here. The nurse, it's critically important that the nurse uses either his or her legs, not their back, to move the client. A lot of nurses end up with injuries because they use poor body mechanics. So remember body mechanics when you are effectively doing these transfers. They will help prevent back injuries. And it's also a good idea to use pull sheets when moving patients around in the bed. A pull sheet is something that will prevent friction on the client, and you can move them from place to place. Again, one of the things that's critically important to remember when you're doing transfers of any sort, if you don't believe you can do it by yourself, or if there's any question, seek assistance. It's always better to have too many people there than not enough and get in a situation where there's an unsafe something going on. Again, on the Nclex exam, if you need someone to help you do a transfer, that person is available, ready and willing to help you. Now, something else that we'll do with regard to basic care and comfort is we'll teach clients activities of daily living. And these are things such as bathing, dressing, feeding. And when you're working with teaching activities of daily living, you need to assess the client's abilities. You need to observe the client and find out what they can do for themselves. We don't want to be doing things for clients that they are absolutely able to do for themselves. But on the other hand, we don't want to assume that they can do something and then have them unable to complete that activity. Another critical important point with activities of daily living is you start with gross movements and follow with finer movements. Again, it's much like a child as they grow up. They start with very gross movements and then they can do the fine motor skills. Now, when you're dealing with activity, you will extend it according to the client's tolerance. Not what you think they should do, but what the client is able to tolerate, which means you'll be assessing the client as you work with them with the activities of daily living. Are they becoming short of breath? Are they getting diaphoretic? Has their level of alertness decreased? These are the type of things that you will be looking at. And it's critically important to give clients positive feedback after each accomplishment. If there was a series of tasks you were going to be doing, you wouldn't wait to the end and say something, that was great. What you would do is along the way, give them positive feedback to know that they are doing something to help themselves and that they are being successful in what they do. If they need, find changes in what they're doing, by all means offer constructive criticism, get them motivated, get them up with what they're doing, and again, the feedback is critically important. Okay, let's talk about some of the different types of exercises. Now, we told you why exercise was important. Let's talk about some of the different therapeutic exercises that can be done. And we're going to start from probably the least patient involved to the more patient, or at least nurse involved to the more nurse involved. I'm sorry, we're going to backwards. We're going to start with the most nurse involved to the least nurse involved. Let's start first with passive range of motion. Passive range of motion is performed by the nurse and is done to maintain joint movements and circulation. This, for example, would be used with a client that is comatose. They are unable to move any part of their body themselves, so the nurse would do passive range of motion, and the nurse would move all body parts through their normal range of motion. We'll go up a step, and this is active assistive. Now, active assistive range of motion is performed by the client with the assistance of the nurse. And in this case, it's done to encourage muscle function. So you can see in this case, this active assisted would not be done for a client that's comatose. The client would have to be able to somewhat assist with this type of range of motion. Let's go on to the next type of range of motion. With active range of motion, this is performed by the client without the assistance of the nurse. The nurse might observe the client do this, but the nurse does not actively participate. And active range of motion will help increase muscle strength. Now, the next step up is active resistive range of motion. Now, this again is performed by the client without the assistance of the nurse, but the key point here is it is performed against resistance. Usually 5-pound weights are used, and active resistive range of motion increases muscle power. So that's why it's performed. Okay, another type of range of motion are what we call isometric exercises. These again are performed by the client without any assistance of the nurse. What they do with isometric exercises, they alternately contract and relax a muscle. The reason they do this, well, okay, a key point is they actively contract and relax a muscle, but the joint remains immobile. It's kind of like if you would clench your teeth. Nothing moves, it's just a contraction and then a relaxation of the muscle. Kegel exercises, again, are an example of an isometric type of exercise. The reason they do isometric exercises is to maintain the strength of the muscle when the joint is immobilized. Now, can you think of a good situation where isometric exercises would be used, or one that would be important to use them? Yes, if a patient is in a cast, they should be doing isometric exercises to maintain the strength of the muscle. Now, if my arm is in a cast, I can't move the joint, but I can alternately contract and relax the muscles in my arm. That will help keep muscle strength up even while the joint is immobile. Okay, we've talked a little bit about exercises. Now, one of the issues with basic care and comfort is immobility. And it is essential that you know about the hazards of immobility and what the nursing activities will be to both prevent and deal with these hazards. Let's talk first about one of the chief hazards of immobility or complications, decubitus ulcer. Patients that are immobile may develop decubitus ulcers, and it may extend into osteomyelitis, which is an infection of the bone. The type of equipment you will use to prevent decubitus ulcers are draw sheets, again to help move the patient in bed. You may place the patient on an air mattress or flotation pads. The patient should have elbow and heel pads on. Again, if you've ever been in a hospital bed and tried to move around, the beds don't give much. So if you use your elbows to kind of push yourself up or your heels to dig in to move, they get abraded very easily. So elbow and heel pads will prevent this. Sheepskin, again, a very soft, kind of fluffy pad under the patient will help prevent the development of decubitus ulcers. Patients that are going to be immobile for long periods of time will use equipment such as the striker frame or the circle electric bed that will flip the patient kind of pancake-like, if you will, from side to side. Other things that you want to deal with decubitus ulcers, again, you want to prevent them. It's a whole lot easier to prevent them than to have to deal with them or treat them. You want to turn the patient frequently. And if the patient is able to ambulate, you will get the patient up and out of bed. Again, circulation will be restored, pressure will be relieved off pressure points, and decubitus ulcers will be prevented. If the patient cannot get out of bed, again, good skin care is critically important. You want to massage the bony prominences. You want to apply lotion again in addition to turning them. And the patient's diet is very important also. You want to make sure they have enough protein, vitamins, and minerals to both maintain the skin as it is and to do rebuilding should an injury occur. Okay, so we've talked about decubitus ulcers. Again, prevention is critically important. Patients that have good nursing care usually do not develop decubitus ulcers. Let's talk about another complication of immobility, which are sensory input changes. With this type of thing, the patient, if there is a sensory input problem, they may become confused and disoriented, and that then brings up safety issues. So let's look at the first thing we will do to hopefully prevent sensory input changes. Well, one of the things that's easy to do is to frequently orient the client to person, place, and time. Hello, Mr. Jones, it's Monday morning, it's, 10 o'clock, that type of thing. You're at St. Joseph's, just, how are the wife and kids? That type of thing will help the client get enough sensory stimulation to remain alert and oriented. It's also helpful to place a clock and a calendar in the patient's line of vision. And many acute care setting, hospitals, and long-term facilities are beginning to do this. Again, they found that it is very important or very helpful to maintain the patient's sensory input so the patient does not become confused or disoriented. Let's talk about another complication of immobility, and that's osteoporosis. If a client that is immobile develops osteoporosis, they may develop pathological fractures and renal calculi because the calcium leaves the bones and gets involved in the urinary system. Let's talk about what we can do to prevent osteoporosis. Well, one of the best things to do to prevent osteoporosis is to have weight bearing on the long bones. Now, this you might say, well, okay, this is the same thing we do for postmenopausal women to prevent osteoporosis. Absolutely. Weight bearing on the long bones keeps the stress on the bones, and the calcium stays where it is. It doesn't leak out, and the bone does not become porous. Another important thing to prevent osteoporosis is a good balanced diet, and we talked about that, as you remember, back when we talked about decubitus ulcers. So there's more than one reason for us to really address the client's nutritional needs. Another way to prevent osteoporosis, and this especially in postmenopausal women, is estrogen replacement therapy, or ERT. Again, we talked about this when we talked about osteoporosis and the type of problems that it can happen or can occur. Let's talk about another complication of immobility. In this case, it's negative nitrogen balance. Patients with negative nitrogen balance, this may cause anorexia and weight loss, so we want to prevent it. What we will do to prevent negative nitrogen balance is give the patient, or have the physician will many times put the patient on a high protein diet and provide small frequent feedings. Let's take a look at the next complication of immobility, which is hypercalcemia. With hypercalcemia, the patient may develop impaired bone growth. So what we will do here is we may reduce the calcium in the client's diet. Again, so the calcium does not increase over what it should be, and we will encourage fluids. So any calcium that gets in the serum gets flushed out or pushed out so renal calculi do not develop. Let's take a look at another complication of immobility, which is an increased cardiac workload. Patients that are immobile may have an increased cardiac workload or develop this and may end up with tachycardia and some cardiac issues. So let's take a look at how we're going to prevent an increased cardiac workload. Well, one is to provide equipment, which is a trapeze, over the patient. If the patients use a trapeze, that will allow them to move in bed without pushing down and doing the Valsalva maneuver. Remember, when you push down and strain against your glottis, that's the Valsalva maneuver, and it interferes with cardiac workload or output. So if we provide a trapeze, the patient can pull down without holding their breath and move them successfully in the bed. The other thing is to teach them, to let them know, if you're moving yourself in bed, don't hold your breath. You might tell them to forcibly exhale, going, ha, when you move. That way they won't be holding their breath, and there will not be an increased cardiac workload. This is especially important for clients with cardiac histories. Let's take a look at another complication of immobility. And again, this is one that I'm sure you're very familiar with, and this is the development of contractures. Patients that are immobile and don't go through normal range of motion will develop contractures that will end in deformities. Let's take a look at the type of equipment we'll use to prevent the development of contractures. Well, we'll use pillows. We'll use trochanter rolls, again, to prevent the external rotation of the legs And you should know where and how to place both the pillows for positioning and the trochanter rolls. Sometimes Nclex will ask you these type of questions. And again, the use of a footboard to keep the foot at a 90-degree angle so you don't end up with foot drop. Another thing we'll do, and this is critically important to prevent the development of contractures, is to frequently change the client's position. Move them in bed, put them on a regular turning schedule, and if it's a client that's comatose, you might want to put a turning schedule, tape it to the head of the bed. You know, right, left, back, side, just so everyone knows, you know, you're rotating them at a certain time in a certain way, so you don't go in and say, well, what should I do? Back, side, you know, it's a normal routine, and it allows the body to be turned so contractures don't develop. And again, we talked about the exercise and how critically important it is to maintain joint movement and prevent contractures. Let's take a look at another complication of immobility, and this is thrombus formation. With thrombus formation, if this is not addressed early or prevented, the client may develop pulmonary emboli, which can be life-threatening. So let's take a look at the type of equipment we'll use to prevent thrombus formation. What we'll use is TED hose or elastic hose. These are the sequential type of stockings that promote venous return. They prevent pooling of blood in the extremities that could set up a focus for a thrombus formation. Another thing we'll do, and again, this is easy to do, but critically important and very effective, is to have the client do leg exercises for 5 minutes every hour. Here we're going to be doing the flexion and the extension of the toes. 5 minutes every hour. You teach the client to do this, and then periodically you just come in and say, Mr. Jones, how are you doing with your leg exercises, to kind of remind them. But again, if patients know why this is so important and what it will prevent, they will be much more likely to be compliant with what we're asking them to do. Another thing that will help prevent thrombus formation is to change the patient's position, and if at all possible, to ambulate them, get them out of bed. Again, standing and moving works the veins of the legs and causes an increase in venous return. Some things we will not do. We will not use the knee gatch of the bed. This will put pressure on the popliteal space that will cause pooling of blood in the extremity and can set up again a focus for a thrombus formation. Okay, so let's say we don't use the knee gatch. How about a pillow behind the knee? Absolutely not. Again, this would put pressure on the popliteal space and could cause pooling of blood in the extremities. And any type of pain in the leg should be investigated. We will check for Holman sign. And you'll remember that Holman sign is pain in the calf on dorsiflexion of the foot. So when they dorsiflex the foot, if there's pain in the calf, then we know that there is a possibility that the patient has a thrombus. Okay, let's go on to the next hazard of immobility or complication that we want to prevent in our patients that are immobile. And this is orthostatic hypotension. Patients, if they develop orthostatic hypotension, may become weak and dizzy, so we want to prevent this. One of the easy ways to prevent this, again, is that we will have them change their position slowly. A patient that has been in bed for a period of time, their body gets used to not pushing blood against any sort of gravity. It's all even because it's flat. When you change their position, and now this person who's been flat for, let's say, 2 weeks, is going to sit up on the side of the bed and do the transfer that we discussed before safely. What we would do is we would probably raise the head of the bed slowly first to get the body used to being in a semi-upright or upright position. Again, so the blood vessels say, okay guys, we've got to get it going here. We're going to have to work a little harder than usual. Vacation is over. Again, if you change the patient's position slowly, that will help prevent the development of orthostatic hypotension. And the same is true, you want to increase activity gradually. You would not come into the person who is just out of a coma and say, okay, we're going to get you up today and we're going to walk the length of the hall. Today it might be that we're going to sit you up at a 45-degree angle, and then this afternoon we're going to sit you up at a 60-degree angle. You want to increase activity and move them very slowly so they don't become weak and dizzy, because again, there's a safety issue here. If they develop orthostatic hypotension where the blood pressure suddenly falls, the patient can black out and fall, and then you have a problem. Let's talk about another complication of immobility, and this is stasis of respiratory secretions. If patients develop stasis of respiratory secretions because of lack of good nursing care, they may develop hypostatic pneumonia. And what we want to do to prevent the development of hypostatic pneumonia, and again get rid of stasis of respiratory secretions, is we want a TCDB. That is, turn, cough, and deep breathe the patient. Again, this should be done on a regular routine where we know every 1 hour, every 2 hours, we go in, we turn, we cough, we deep breathe the patient. Again, we should teach the patient or let the patient know why we're doing this, how critically important it is. It's not that we just had nothing better to do with our time, so we're in bothering them again, but if they know to expect us, they know what they're going to be doing and why it's so important, what it's preventing, they're much more likely to be compliant with the regime. And again, another thing we can do to prevent stasis of respiratory secretions is to do postural drainage, again, where we use gravity to help the patient expectorate the secretions that they have. Let's go on to the next complication of immobility, and this one is constipation. Patients, if they develop constipation, may develop a fecal impaction, and this is both uncomfortable and can cause problems. You can end up with a bowel obstruction. Let's talk about what we can do to prevent the hazard of immobility that's constipation. Well, the best thing to do is to get the patient out of bed. Again, movement and that type of thing, ambulation, increases peristalsis, gets the GI tract moving, and prevents the development of constipation. Another critically important thing is to increase the fluids and the fiber in the diet. Now, the normal fluid intake is 2,000 cc's per day. So if we're increasing fluids, we're going to increase fluids to 3,000 cc's per day. And again, we want them to have whole grain breads and that type of thing to increase the fiber in the diet. It will help prevent constipation. A critically important thing to prevent constipation is something that I think nurses don't often think about, and that's to provide privacy to the patient. Not many people defecate and urinate in the presence of somebody else. We like our privacy when we're on the throne or however you want to refer to it. So again, if you have a patient in a semi-private room or you have to assist the patient on and off the bedpan, make sure to provide privacy. Pull the curtain, shut the door, tell them that you will check back with them in 3 minutes, give them the call bell so if they need you before then, but let them know that they're going to have a period of privacy. Because again, that's something that we've kind of conditioned ourselves to expect and can interfere with normal bowel elimination. Another thing that can be done that will be helpful is many times the physician will order stool softeners such as Colace that will help soften the stool so it's easier to pass. Let's go on to the next complication of immobility, and this is urinary stasis. If patients develop urinary stasis, they may end up with urinary retention and then infection. Because again, urine that stays in the bladder, can set up a focus of an infection. So let's talk about what you can do to prevent urinary stasis. Well, the first thing is kind of like what I was talking about before. I don't know if any of you have used a bedpan in bed, and I think it's something that all nursing students should be required to do because it is difficult to do. We've been conditioned and patterned to void in a sitting position. Try voiding laying on your back, and what you almost have to do is tell yourself, I'm not in bed, it is okay, because we're so conditioned against, wetting the bed and that type of thing. So if at all possible, let's get the patient in the normal position to void. If you can, elevate the head of the bed, that type of thing. Bedside commodes can be used if there's not a contraindication to doing it. Ambulating the patient to the bathroom, again, is something, because there is a normal position to void, and it's difficult to void outside of that normal position. Another thing we can do to prevent urinary stasis, and that's increase fluid intake. Remember I said normal intake is 2,000. We want to increase this person's fluid intake to around 3,000 unless there's a contraindication to doing that. For example, someone in renal failure, you would not do that or could not do that. And the same is true for someone in congestive heart failure. It would be contraindicated in their case. Another thing we can do to prevent urinary stasis is to put the patient on a low calcium diet. And the last thing is to acidify the urine. And I'm sure you all remember cranberry juice is the juice that's used to acidify the urine. It helps prevent the development of urinary tract infections because bacteria doesn't like to grow in an acidic environment. Let's take a look at another complication of immobility, and this one is boredom. Patients that become bored may become very restless, and then you may get into some safety issues where they try and get out of bed or do something that they shouldn't do. Let's talk about the equipment you'll use to prevent the development of boredom. These would be things such as radio, television, books, or phone calls. Another thing you might do is to encourage visitors. Encourage the family to come and see them, stay with them. Bring up cards, bring, board games, do something to actively engage the patient in both conversation and some type of activity. And the physician may schedule the patient to go through occupational therapy, again, to prevent boredom. This is especially important with clients in long-term facilities and patients that are going to be hospitalized for a long period of time. For example, after a serious burn, you know that there's going to be a long period of hospitalization. Let's take a look at the last complication of immobility, and that is depression. Patients that develop depression may also develop insomnia. So what can we do to prevent the development of depression? Well, one good way to do it is to encourage the patient to do self-care. That way they're doing something, they can feel good about what they're doing, and again, we talked about the positive feedback we want to give clients as they do things for themselves. Another thing you want to do with depression, if you're having them do things, again, we talked about this a little bit before, you want to start with simple, gross activities. You want the patient to be successful with what it is that they attempt to do. You don't want them to build on failure after failure. So start with simple, gross activities. And you will increase the activities to the client tolerance. You want to, again, assess them, make sure they're not becoming short of breath or weak or dizzy. And again, we talked about this positive feedback. Critically important. Let the patient know that they are valued, they have self-worth, they are doing things to help themselves get better. It gets them much more involved in their care. Again, letting them know what we're doing, why we're doing it, and how they can help will help prevent depression. Okay, those are the hazards of immobility that are so critically important and are frequently tested on the Nclex. Let's now talk about some therapeutic positions, because often on the Nclex they will, in the midst of a question, talk about a specific position. And it's important that you begin or have a mental image of what that position is. Let's start with the easiest one, which is supine. Supine is flat in bed. This will prevent hip flexion. Another type of supine is what we call dorsal recumbent. Dorsal recumbent is supine, but the knees are slightly flexed. Again, it kind of decreases the pull on the abdominal area. Another therapeutic position is prone. This is face down. This type of position is used, for example, after an amputation. Again, it helps prevent hip flexion. So you put the patient prone. Another position is side lateral. Side lateral we use a lot to help the drainage of secretions. For example, a post-op patient, will position them on their side so if there are secretions from the oral cavity, they will drain rather than be aspirated. Another position, and we use this position a lot, is Fowler's position. Now there are different types of Fowler's position. I'm going to start with the highest and go to the lowest. High Fowler's position is where you elevate the head of the bed 60 to 90 degrees. Again, 90 degrees would be a right angle, so this person is really sitting up in bed. Fowler's position, just plain old Fowler's position, is where the head of the bed is elevated 45 to 60 degrees. Going down, semi-Fowler's position. If the patient is to be put in semi-Fowler's position, the head of the bed is elevated 30 to 45 degrees. And low Fowler's position is where the head of the bed is elevated 15 to 30 degrees. And again, these are numbers you need to commit to memory. So if the patient is to be put in high Fowler's, you know it's 60 to 90. Semi-Fowler's, 30 to 45. Let's go on and talk about another position. This position is modified Trendelenburg. This is where the patient's feet are elevated about 20 degrees. However, the knees are straight. The trunk is flat and the head is slightly elevated. You may remember this is the position we put patients in with shock. We no longer use the Trendelenburg position itself, which is a head down position. And the reason we don't is that then the lungs have to push against the diaphragm with every inspiration, and it decreases the amount of air that can be exchanged. So modified Trendelenburg, again, feet elevated 20 degrees, knees are straight, the trunk is flat, and the head is slightly elevated. The next therapeutic position I'll mention to you is elevation of an extremity. And we do this, again, to help promote venous return. For example, if my legs become edematous, as I'm talking with you, I would then sit down and elevate them. And that would help venous return. Another position that isn't mentioned here, but I'll mention briefly, is lithotomy. We talked about this when we talked about health promotion and maintenance issues. This is where, done with a woman, she's flat on her back, her thighs are flexed, and her legs are abducted or moved apart. And it's usually used for pap smears and pelvic type of examinations. Okay, so those are the type of therapeutic positions that we're going to be using when we talk about things dealing with basic care and comfort. Let's now talk about some assistive devices. The first assistive device we'll talk about is a tilt table. A tilt table is used to provide weight bearing on long bones. Remember that client I told you about before that was comatose, and I said if they had been laying flat for a period of time, we would not want to get them upright right away because of the problem with orthostatic hypotension? Well, they would perhaps use a tilt table. Again, this would help put weight bearing on long bones. It helps prevent decalcification of bones, again, because of the stress or the force on the bones. It's also done to stimulate circulation, especially to the lower extremities. But again, it helps get a patient upright after being flat for a period of time. When the tilt table is used, many times we will put elastic stockings or TED hose on the client. Again, this will help with venous return so the blood does not pool in the lower extremities. Remember, after being flat in bed a period of time, the body's gotten very used to not having to work very hard against gravity. And when you change position and gravity kicks in, again, the blood would pool in the lower extremities unless we would use the elastic stockings or TED hose. What they do is you start flat and they gradually increase the tilt in 5-degree to 10-degree increments. So it might be 5 degrees or 10 degrees up, and then another 5 or 10, and another 5 or 10. And you can see that we're taking this person who's been flat for a long period of time and gradually putting them upright. Now, what you want to do for a patient on a tilt table, it is critically important to monitor their blood pressure. Again, the blood vessels now have to contract and work against gravity, and we don't want the patient to their blood pressure to bottom out. So while using the tilt table, you will assess the client's blood pressure. If the blood pressure falls, or the client becomes dizzy, gets pale, becomes diaphoretic, or they develop tachycardia, which means you're monitoring their pulse, you will stop the procedure. Again, you will monitor blood pressure, pulse, and you will observe the patient. You'll assess how they're doing with the use of the tilt table. If the blood pressure falls, or they become tachycardia, their pulse rate goes up, or they become dizzy, get pale, or diaphoretic, you will stop the procedure. It means you're going at it too quickly. You need to kind of slow down a little bit. Again, so the blood vessels get used to working against gravity. Let's talk about another assistive device, and this is crutches. We'll talk about how to measure crutches. We'll talk about the different crutch gaits. Again, this is a frequently tested topic. Let's talk first about how you would measure for crutches. You would measure 2 finger breadths below the axilla. That's how you would measure to make sure the crutches are the right size for the patient. And a critically important issue here is crutches, the weight of the patient's body should not be borne on the axillary area. That should be borne on the hands, on the hand pieces. Otherwise, the client or patient will develop what we call crutch palsy. It will injure the nerves in the axillary area. The correct position of the crutches in the start position is 8 to 10 inches off to the side. The arms, when they are held, when your arms are on the hand pieces, the elbows should be flexed 20 to 30 degrees. And again, if the client is using crutches for walking, if they become short of breath or diaphoretic, they should stop and rest. Okay? Let's, again, we'll go through all this, and I'll show you how to use the crutches. Let's review that again. To measure for crutches, the top of the crutch should be 2 finger breadths below the axillary area. Because remember, the patient's weight is going to be borne on the hand pieces, not on the axillary area. That would result in crutch palsy. And to position the crutches, they're 8 to 10 inches out to the side. Okay, so that's how you measure and, again, weight on the hand pieces. Let's now talk about the crutch gaits. We're going to start with the 4-point crutch gait. And the easy way to remember the different crutch gaits is to count the number of pieces, if you will, that are hitting the ground. So for a 4-point gait, it would be left crutch, right foot, right crutch, left foot, left crutch, right foot, right crutch, left foot. And you can see that I have 4 pieces hitting the ground. 1, 2, 3, 4. 1, 2, 3, 4. And you can see also that this is a weight-bearing type of crutch or walking that we're doing here. So this type of crutch walking, the 4-point gait, is only done with weight-bearing. Let's do the 2-point gait. This is a little faster gait. And what I'm going to do is going to be left crutch, right foot, right crutch, left foot. And you can see 2 points are hitting the ground. This is 1, 2, 1, 2. Again, you can see also that this is a weight-bearing type of crutch walking. So it would only be done with patients that are allowed to do weight-bearing. Let's do a 3-point gait. With a 3-point gait, it's going to be 2 crutches together with the weak leg. Okay, so in this case, it would be the crutches, and let's say my right leg is weak for point of illustration here. So I'm going to do both crutches in my right leg and then my good leg, my left leg. Both crutches with my right leg and then my good leg. Okay, and you can see that 3 points are hitting the ground. Now, with the 3-point gait, it's either used with partial weight bearing or, again, let's say my right leg is my weak leg or my affected leg. It could be 2 crutches, good leg. Again, I'm supporting my weight on my hand pieces. 2 crutches, good leg. And this can be done with non-weight bearing. And that's critically important, and it is frequently tested on the Nclex. What type of crutch walking gait would you expect a client to do that does not or is not able to bear weight? Let's now talk about another assistive device, which is a walker. With a walker, again, it's similar to crutches. Again, we're going to have the elbows flexed 20 to 30 degrees. When the hands are on the hand grips, you will lift the walker, or the client lifts the walker and moves the walker forward about 8 to 10 inches. Again, these numbers are familiar with what we talked about with crutch walking. If a nurse is helping a client with a walker, the nurse will stand behind the client and hold on to a gait belt that will be around the client's waist. Now, with the client using a walker, if they're using a walker with partial or non-weight bearing, the client will put their weight on their wrists and arms and step forward with the affected leg and the walker at one time, and then follow it with the good leg. Let me do a demonstration. Let's do that again. With the walker, again, the weight will be worn on the hand pieces. Again, the elbow should be flexed about 20 to 30 degrees. And what the client will do will be pick up the walker, advance it forward about 8 to 10 inches, and then walk into it. Now, if the client is doing partial or no weight bearing, they would put the walker forward with, again, my right leg will be my affected leg, would be the walker in my affected leg, and then follow it with the good leg while I bear my weight on my arms. Again, walker in affected leg, followed by good leg. Again, with the walker and all, and the tips of the crutches, they should have good concentric tips so that it's safe. It won't be sliding across the floor. Okay, let's talk a little bit about a cane. With a cane, again, which is an assistive device, again, sounds familiar, the elbow should be flexed about 30 degrees. And the tip of the cane should be placed about 15 centimeters lateral to the base of the 5th toe, or your baby toe. And you will hold the cane, or the client will hold the cane on the good side. Remember, that's their strong side. So let's go through that with a cane. Remember, you hold the cane in your strong side. And again, I'm going to go on the idea that my right side is affected. So you advance the cane and the weak leg together and put weight on the good arm as you bring the good leg forward. Again, cane and affected side, support your weight on the cane, bring the good leg together. Now, to go up and down stairs, it's important that you know how to do this both with a cane and with crutches. And the way to remember this is you go up with the good and down with the bad. It's kind of like good girls go to heaven and bad girls don't, that type of thing. So with both cane and crutches, you will step up on the good leg and then either the cane or the crutches. So again, to go upstairs with cane or crutches, you step up with the good leg and then advance either the cane or the crutches. If you're going downstairs, you step down with the crutches and the affected leg, followed by the good leg. Again, down with the bad, you're going downstairs, up with the good if you're going upstairs. Okay, let's take a look at another assistive device, which is a Hoyer lift. A Hoyer lift is a mechanically operated metal frame that has a canvas sling. What you will do in doing a safe transfer with the Hoyer lift is, first of all, you will lock the bed. You don't want it moving around while you're moving the patient around. Another thing that's critically important is it should be a 2-person transfer. One person guides the lift, the other person assists the client. You can't be doing both things at one time. So again, 2 people are needed. What you will do is you will center the canvas sling under the patient by rolling them side to side. You will then attach the sling to an overhead arm of the Hoyer lift. The patient will cross their arms across their chest, kind of in this, a position such as this. Then you will pump up the lift. And again, one person's studying the client, the other person's doing the pumping. Then you will move the Hoyer lift or move it over to where you want to put the patient. Again, someone steadies the client as the client goes down, and the other person releases the pump, and the patient or client settles into the chair. Again, it's necessary to have two people to effectively do a safe transfer using a Hoyer lift. Let's take a look at another assistive device, which is a sliding board. Again, in this case, you want to lock the bed and the wheelchair. We're going to effectively do a transfer between a bed and a wheelchair using a sliding board. What you will do is you will remove the arm from the wheelchair on the side that you're going across. You will powder the board, again, to make it slippery or sliding. One part of the board goes under the patient's buttocks, the other goes on the surface of the wheelchair. Again, it's powdered. What we're going to do is the patient's going to push up on their hands, lift their buttocks up, put them on the board, and then we're going to assist them to slide on this smooth surface over and into the wheelchair. Again, if needed, two people should be there to effectively and safely do this transfer. Okay. Let's talk now. We've talked about some of the equipment and some of the issues that that have to do with basic care and comfort. Let's now talk about some of the conditions that limit mobility. With talking about conditions that limit mobility, one thing that's important to know and is frequently tested is a myelogram. And the type of questions you may see on the Nclex dealing with myelogram is you'll need to know the procedure, how it's done. Now remember, myelogram is an X-ray of the spinal canal using radio-opaque dye. And whenever you talk about dye, you have to check the client for allergies. Another thing that's frequently tested is what is the difference in nursing care after a myelogram using a water-soluble dye versus the nursing care that's done after using an oil-based dye for the procedure. So let's talk about a myelogram. What type of preparation does the client need going into this test? Well, first of all, we want them well hydrated the 12 hours before the test. We will give them also cleansing enemas to clean out the GI tract. And any seizure-promoting medications will be withheld. These are the phenothiazide derivatives and the central nervous system stimulants. Patient goes to a myelogram, they come back to the floor, then what do? Well, after the procedure, if the client has had a myelogram using a water-soluble dye, we will elevate the head of the bed 30 degrees. The water-soluble dyes are the metrozamide type of medications, and again, remember they are not removed after the procedure. So they come back after using a water-soluble dye with the myelogram, we elevate the head of the bed 30 degrees. If that is not the case, if they used an oil-based dye, the patient will remain flat in bed. In either case, they will be on bed rest for 24 hours, and we will encourage fluids. In one case with the water-soluble dye that is not removed, we want to get it in dilution and excrete it. With the oil-based dye that is removed, we want to make sure and replace the fluids that were lost. Okay, one of the conditions that limits mobility is the type of thing with disc problems and all, and a laminectomy many times is the treatment done to fix that. And one of the frequently tested topics on the Nclex is how to position a patient after a laminectomy. Now you remember a laminectomy is where they remove a portion of the lamina to expose a disc that is then going to be removed. And with the laminectomy, it can either be done with or without bone grafts or fusion. So let's talk about the patient, what needs to be done for a patient before a laminectomy. Well, what they may do preoperatively is provide moist heat for comfort. That will help with the back pain that the patient may be experiencing. We'll also position them in the Fowler's position with moderate hip and knee flexion. Again, we talked about positioning before, and now when I say Fowler's position, you should know exactly what that means, what elevation the head of the bed should be. And what elevation should that be? Yes, 45 to 60 degrees. Another thing that will be done with back problems before surgery is we will teach the patient to do isometric exercises to strengthen their abdominal muscles, and these may be pelvic tilts and that type of thing. And again, the patient before surgery may be on muscle relaxants, the NSAIDs or nonsteroidal anti-inflammatory medications such as Motrin, and may be receiving other analgesics. Another thing that may be done before a laminectomy is the patient may be put in traction. The reason they use traction is to separate the vertebra, and this relieves pressure on the disc. Again, the traction is used to separate the vertebra. And they can use what is known as a TENS unit. TENS stands for transcutaneous electrical nerve stimulation. And what they do with this is they pass a small current into the area either at or near where the pain is, and it interferes with the conduction of the stimulus or the pain sensation. Okay, this is all done, remember, with disc problems before a laminectomy is done. After the laminectomy, let's talk about the type of nursing care you will be providing to this patient. First of all, when they come back to the floor from surgery, you will assess their circulation and sensation. Again, remember, assessment is always first. To move them in bed, you will log roll them Q2 hours or every 2 hours. And again, log roll, think of a log. A log doesn't twist. A log only rolls in mass. So to log roll someone, you will put a pillow between their legs, have their arms at their side, and they will roll just like a log would roll down a hill. Another thing you will do after a laminectomy is you will encourage the client to do calf exercises. And again, this is the type of thing you should know about because it's frequently tested. And you'll assist the client with ambulation and make sure they know to keep their back straight. Again, you want to prevent any torsion or twisting of the back. The type of teaching you should do for a client after a laminectomy before they go home. They need to know to do daily exercises to keep their abdominal muscles strong, again, to prevent pulling on the back. They should know to sleep on a firm mattress. Some people go home and put a board under their bed or buy a new mattress. The patient should avoid the prone position. Clients that are used to sleeping on their stomach have a little bit of difficulty adjusting to now sleeping in a lateral position or on their back. And they should avoid heavy lifting. Again, that would put pressure on the back. It's also helpful to teach the client good body mechanics. Maybe they're lifting with their arms instead of with their legs. They need to keep their back straight. They need to use good posture, stand up straight, like our mothers always taught us to do with our shoulders back. Again, patients after a laminectomy should avoid long periods of sitting, standing, walking, or driving because it will put stress in the back area. Let's change topics here and talk a little bit about developmental dysplasia of the hip. There are certain things you need to know because, again, this is a frequently tested topic on the Nclex. You need to know what hip dysplasia looks like, and we'll talk about the symptoms in a minute. You need to know that the treatment varies with the age of the client, and you need to know what treatment is appropriate at what age range. And again, we're going to talk about this more than once. You need to remember to meet the growth and developmental needs of the infant or child. We don't want to just focus in on the fact that they have hip dysplasia. We want to focus in on, make sure we address their developmental needs as they grow and mature. So let's talk about assessment of hip dysplasia. Remember, hip dysplasia is where the acetabular is unable to be held unable to hold the head of the femur. Again, there's a problem. The acetabulum unable to hold the head of the femur. What you will see with hip dysplasia, there will be uneven gluteal folds and thigh creases. And it's important to remember that they will be deeper on the affected side. Again, the thigh creases and gluteal folds are deeper on the affected side. Usually the child will have limited abduction. Again, remember, abduct is to move away. Will have limited abduction of the hip. They will experience what we call Ortolini sign. Ortolini sign is where you hear a click when the hip is abducted. Again, you will check for this with the baby or the infant lying on their back. And there will be a shortened limb on the affected side. Again, that's another way to see what side of the body is affected. Other assessments you may note, if the child is older, there may be delays in walking. The child may experience a limp or have a waddling gait. So let's talk about what type of things are done for a child with developmental dysplasia of the hip. Again, remember, the intervention varies with the age of the client and the extent of the dysplasia. We'll start first with newborn to 6 months. Usually, in this case, the developmental dysplasia is reduced by manipulation and then splinted with the proximal femur centered in the acetabulum in a position of flexion. Again, newborn to 6 months, reduced by manipulation and then splinted with the proximal femur centered in the acetabulum in a position of flexion. They use a Pavlik harness. The important thing to remember is this harness is worn full time. It is worn for about a 3 to 6 month period until the hip is stable. It's critically important that we teach the parents how to care for the child in the Pavlik's harness, how to protect the skin under it. The child should, for example, wear an undershirt, how to give good skin care. And again, the child should be moved from room to room and, talked with, and their developmental needs need to be addressed. Now let's take a look at an older child. A child 6 months to 18 months, what they will do to treat the developmental dysplasia is they will use bilateral Bryant's traction or a hip spica cast. Again, important to remember to encourage and help with growth and development needs for these children. Let's take a look at an older child. An older child, they may use preliminary traction, but then many times they will use open reduction and a hip spica cast. So again, these are the type of things you need to know for the Nclex. Let's go on to another topic. Let's talk about scoliosis. With scoliosis, again, it's a frequently tested topic. You need to know what screening procedures are used. Many times they're done in elementary schools as part of a health screening or wellness assessment. You also need to know how to care for a child in a Milwaukee brace. So let's talk about what you see with scoliosis. What you'll see is there'll be uneven hips or scapula, and many times the child has poor posture. There may be kyphosis or a lump on the back. And the way you check for scoliosis is you have the child bend at the waist 90 degrees, and you will be able to visualize the deformity. Okay, so that's what you'll see with scoliosis. Let's talk about what is done or implemented for scoliosis. First of all, what they may do is teach the child exercises to strengthen the abdominal muscles. These are similar to the type of exercises we do for patients after a laminectomy. Again, these are the sit-ups, the pelvic tilts, and the push-up with the pelvic tilt. They will strengthen the abdomen. Another thing that can be done is electrostimulation, or surgery is many times done for clients with scoliosis. What they will do is a spinal fusion with a Harrington rod insertion. Another thing that's done for scoliosis is a Milwaukee brace. Now, it's important that you know this. Again, it's frequently tested. A Milwaukee brace is used for a 4 to 6 year period of time. Again, long-term care with this type of brace. The child will wear it 23 hours a day. Yes, 23 hours. They get an hour off for good behavior or an hour off so they can do skin care and bathe. And again, you need to provide good skin care under the brace. There should be a shirt or something underneath the brace, between the brace and the skin, again, to prevent any rubbing or chafing of the skin. But again, worn 4 to 6 years, 23 hours a day. Becomes the child's constant companion. Let's change gears here a little bit and talk about clubfoot. Clubfoot, again, is a frequently tested topic. Let's talk about what you need to know. You need to know how to care for a child in a splint or a cast. And again, you need to know to meet the growth and development needs of the child. Let's talk about what you'll see with a clubfoot. With clubfoot, you'll remember this is a rigid abnormality of the talus bone that's seen at birth. It does not involve the muscles or the nerves or the blood vessels. Again, a rigid abnormality of the talus bone seen at birth. There will be inversion of the heel and inversion and adduction of the forepart of the foot. Again, remember, adduction, you add to midline, so it's toward center. Inversion and adduction of the forepart of the foot. Let's talk about what you do for clubfoot. First of all, they will teach the child and the parents, mostly the parents, because usually this is identified and diagnosed with an infant who is unable to help themselves. The foot exercises you will teach the parents are manipulation. It should be done every 4 hours. What the parent will do is manipulate the foot to the correct position. Again, done every 4 hours. The foot is manipulated to the correct position. It also may be casted or splinted. Initially, if this is done, every few days they will change the cast for like 1 to 2 weeks. Then, as they go in time, they may delay changing the cast to every 1 or 2 weeks. So every couple of days, initially for 1 to 2 week period, like Monday, Wednesday, and Friday for 1 to 2 weeks. Then they will only change it every 1 to 2 weeks, this week and not next, and so on and so on. Another thing they may do with an older child with clubfoot is they may do surgery. And again, with infants, they may use what they call the Dennis Brown abduction bar. This is a horizontal abduction bar with foot plates. Again, abduction, feet apart, away from midline. Okay, let's talk a little bit about joint disorders. Again, joint disorders are frequently tested topics. The type of things you need to know. You need to know the difference between rheumatoid and osteoarthritis. And it's important for you to remember that the goal of care is to prevent deformities. Let's talk about rheumatoid arthritis. The type of things you will see with rheumatoid arthritis, there will be joint pain, swelling, contractures. If it is a child with juvenile rheumatoid arthritis called Still's disease, they may have a rash. With rheumatoid arthritis, it is a systemic disease. It is progressive, and there are remissions and exacerbations. Again, systemic, progressive, remissions and exacerbations. With osteoarthritis, again, what you will see, it looks similar. There is joint pain, swelling, and contractures. But this is a non-systemic disease. It is a degenerative disease, and there are no remissions. It goes in one direction only. So it gets progressively worse. It doesn't get better, worse, better, worse. Okay, let's talk about the nursing care, because the nursing care doesn't change a lot between the rheumatoid and the osteoarthritis. What you will do for a client with either rheumatoid or osteoarthritis, you want to balance rest and activity. You want to have them as active as possible, but not so that they become fatigued. Again, remember the goal we talked about here. The goal is not comfort of the patient, because comfort, they will not be comfortable in doing this, but the goal is to prevent deformities. Again, that's frequently tested on the Nclex. If they give you a choice between comfort and preventing deformities, go with preventing deformities. Another thing that will be done with rheumatoid and osteoarthritis is they will use medications. Analgesics will be used for pain management. Anti-inflammatory drugs will be used. They may also use heat, and they may splint the joints. Let's talk now about another joint problem, which is gout. Gout, remember, is the type of thing, what you will see again is joint pain, contractures, and swelling. Gout is a disturbance in purine metabolism. It is a non-systemic process, and there are exacerbations where it gets better and worse. The type of thing done or implementations done for gout, you want to have the client on a diet that does not include meats that are rich in purines. These are like organ meats. The client should also avoid foods such as sardines and fish. Another thing you should do for gout is pain management is an issue, and they use analgesics in its treatment. Okay, let's go on to osteoporosis. Osteoporosis is a frequently tested topic. Let's talk about what you need to know about osteoporosis. First of all, you need to know that it is more likely to occur in postmenopausal women. You need to know how to prevent it with the activity and the estrogen replacement therapy, and you need to know the safety issues that go along with it. Okay, let's talk about osteoporosis. Remember, osteoporosis is more likely to occur in postmenopausal women over the age of 45. What you have is a reduction in bone mass. There is usually a decrease in height. The client may experience low back pain and kyphosis, or the bump on the back, the deformity of the back. The type of implementation you'll do for osteoporosis, this client should be on a high calcium diet, high protein diet with additional vitamin D. And again, they may be doing or have estrogen replacement therapy. This helps prevent the development of osteoporosis. Another thing you want to do is to make sure the client uses weight bearing on long bones. Let's go on. We're going to talk now about spina bifida. Spina bifida, again, is a frequently tested topic. The type of things you may be asked about spina bifida. You need to know the difference between a meningocele and a myelomeningocele. You need to know how to prevent infection with an infant with a myelomeningocele. And you need to know how to monitor for an increase in intracranial pressure. Let's talk first about what you'll see with spina bifida. Remember, spina bifida is a congenital anomaly of the spinal canal. There is non-union between the laminae of the vertebra. Again, it's a congenital anomaly of the spinal canal, non-union between the laminae of the vertebra. Let's talk about the different types of spina bifida. The least invasive or problematic type of spina bifida is what we call spina bifida occulta. This is where you have just dimpling at the site. There's no other changes. The next type of spina bifida is where you have a meningocele. A meningocele is a sac-like lesion that is filled with spinal fluid. Now, again, remember we said you need to know the difference between a meningocele and a myelomeningocele. And the way I remember it is a meningocele is a shorter word and it has less stuff in it. Again, meningocele is a sac-like lesion filled with spinal fluid. A myelomeningocele, on the other hand, includes both spinal fluid and the spinal cord element. It is much more problematic because of the addition of the spinal cord element. Let's talk about what you do for spina bifida. And these primarily will deal with the myelomeningocele. Well, first of all, you want to cover the lesion with a moist, sterile dressing to keep it moist. You want to position the infant on the abdomen or the semi-prone position. Many times they'll do kind of almost a sideline semi-prone because they don't want to put the infant in the prone position because of how it decreases the respiratory excursion. Other things you'll do, you will observe the client for signs and symptoms of increased intracranial pressure. You'll remember these are headache, changes in level of consciousness, changes in motor function, and changes in vital signs. You'll observe for signs of meningitis. Again, monitor the infant's temperature. Usually they will do a surgical repair at 24 to 48 hours. And after surgery, you will monitor for shock and respiratory difficulty. One of the things that's many times associated with the spina bifida is what we call hydrocephalus. Let's talk about hydrocephalus. Hydrocephalus, what it is there's an increase in the cerebrospinal fluid within the ventricular system, and this results in an increase in fronto-occipital circumference. Usually the child will present with a very prominent forehead, sunset eyes, and a high-pitched cry. The type of implementations done for hydrocephalus. It is treated by insertion of a shunt. This can be a ventriculoperitoneal shunt that connects the ventricles of the brain with the peritoneal cavity. It can be a ventricular atrial shunt, which connects the ventricles of the brain with the right atrium. Those are the two of the type of shunts that can be used. After a shunt is put in, you want to make sure and monitor the functioning of the shunt. And the parents need to know that the shunt will need to be modified as the child grows. Let's go on now and we'll talk about neuromuscular disorders and what you need to know. Again, you know what I'm going to say next? These are frequently tested topics. You need to know with the neuromuscular disorders, one of the key nursing interventions is to maintain safety, and we want to promote activities of daily living. Let's talk about the first neuromuscular disorder, and that's cerebral palsy. What you will see with cerebral palsy, or let's talk first about what it is. What you have is voluntary muscles are poorly controlled, and it's caused by brain damage. What you will see is the child or infant will be spastic. There will be spasticity, rigidity, ataxia, which is dizziness, and the child will do repetitive, involuntary, gross motor movements. Again, repetitive, involuntary, gross motor movements. Let's talk about what you do for cerebral palsy infants and children. They will use ambulation devices and also physical therapy and occupational therapy. They also will use muscle relaxants and anticonvulsants because many times because of the brain damage, the child will have seizure issues or seizure problems. So anticonvulsants will be used. And many times they will put a child or an infant with CP or cerebral palsy on a high-calorie diet. Let's talk about another type of neuromuscular disorder, and that's muscular dystrophy. With muscular dystrophy, what you have is atrophy of the voluntary muscles. This produces muscle weakness, lordosis, or sway back. Remember, we talked about that as a definition. And many times you'll pick it up because your child that used to be able to run and jump and do all kinds of things begins to fall and fall repeatedly. The type of treatment or implementation they do for muscular dystrophy, or MD, is they put braces on the child's legs to help with ambulation. Again, it helps with the muscle weakness. And again, you want to balance rest and activity in this child. Let's talk now about another problem with nervous function, and that's disturbed transmission of nervous impulses and the type of things you need to know. When we talk about disorders that involve a problem with the transmission of nervous impulses, you're going to need to know the symptoms involved with the particular disorder and what medications are used. So let's talk first about Parkinson's disease. With Parkinson's disease, it is caused by a deficiency of dopamine. what you will see is the client will experience tremors, they will be very rigid, they will have a propulsive gait, meaning it's kind of like a runaway train. Once they start walking, they walk and they move, and you almost have to stop them physically. They also have a mask-like face. They don't change expression very often. Let's talk about the type of implementation you'll do for Parkinson's disease. Well, one of the things we talked about, the runaway gait or the propulsive gait, you need to teach them ambulation modification techniques. These are things such as a goose-stepping walk, kind of like a soldier would march. You also want to teach the client to walk with a wide base, keep their feet apart so it helps with their balance. You also want to tell them to swing their arms as they walk. And when they turn around, they should turn around slowly using small steps. So these are some of the ambulation modification techniques we'll teach a client with Parkinson's. Another thing we'll do is we'll teach them range of motion exercises to make sure that they keep their joints in full motion. Now, the type of medications that are used for Parkinson's, and you should be familiar with these medications, both when they're used, why they're used, side effects, and especially nursing implications. These are Artane, Congenital, L-Dopa, Parladel, Sinemet, and Symetrol. Okay, so again, review these medications. Let's go on to the next disturbance in nerve transmission, which is myasthenia gravis. With this medication, what you will see, it's due to, with this disease, I'm sorry, not medication. With this disease, it is due to a deficiency of acetylcholine. What you will see is muscular weakness produced by repeated movements. Again, so as the person moves more and more, the muscle weakness occurs. They have dysphagia and they have respiratory distress. Again, usually the terminal part of myasthenia is they die in respiratory distress. Let's talk about the different implementations you do for myasthenia gravis. Well, first of all, good eye care is important. And you want to provide a restful environment because remember the muscle weakness is produced by the repeated movement, so they need to balance rest and activity. The medications that are used are the anticholinesterases, the corticosteroids to decrease the inflammatory response, and the immunosuppressants because they believe there is some immunological issue dealing with myasthenia. Now, in caring for the patient with myasthenia, one of the things you want to prevent is what we call myasthenia crisis. This can be caused by infection, emotional upset, or the use of streptomycin or neomycin. Again, you want to prevent myasthenia crisis. What you will see with myasthenia crisis is there will be a sudden inability to swallow, speak, or maintain the client's airway. Again, sudden inability to swallow, speak, or maintain a patent airway. And you can see why they call this a crisis. So it's imperative that you intervene early and quickly and make sure and reestablish the patient's airway. Let's go from myasthenia. Now we're going to talk about multiple sclerosis. With multiple sclerosis, this is caused by demyelination of the white matter in the brain and spinal canal. That's the cause of it. What happens is it results in changes in vision, sensation, and motor function. And many times there's some emotional instability or lability involved with MS or multiple sclerosis. Let's talk about the implementation. These type of patients will go through bladder and bowel training because again they have a problem with incontinence or retention. So the bladder and bowel training will help them. We will go teach them how to do and go through with them range of motion and coordination exercises. This helps with the motor function changes that the disease causes. Medications that are used for MS or multiple sclerosis are muscle relaxants. And again, it's very important to provide emotional support for patients with MS, both for the patient and for the families and significant others. Let's talk now about amyotrophic lateral sclerosis, also known as ALS, also known as Lou Gehrig's disease. The type of assessment you will see with this, ALS or amyotrophic lateral sclerosis is a progressive degenerative disease of the motor neurons. What you will see is there will be atrophy of the muscles with fasciculations. And fasciculations is a fancy term meaning these are brief muscle twitchings. The client will also experience dysphagia and muscle wasting. They also experience respiratory insufficiency, and respiratory insufficiency or problems is the usual cause of death with ALS. The type of implementations you'll use, you want to maintain this client's nutrition, good nutrition. Again, physical therapy can be used, and a lot of psychological support is important both for the client and the client's family and significant others. Okay, so that kind of concludes our discussion of some neuromuscular transmission problems or diseases. Let's now go on and talk about interventions the nurse can do to promote comfort. Well, when you're talking about comfort, one of the things that comes to mind immediately is pain. We do comfort measures to help prevent and decrease pain. So let's talk about what you'll see if the client is having pain. Now, let's first of all define pain. The books define pain as what the client says it is, and it occurs when the client says that it's happening. Again, it's what the client says it is, and it happens when the client says that they're having pain. And you'll be able to pick up some significant changes in the client's behavior and some of the assessment things if the client is undergoing pain. Not always, but many times. The type of assessment you'll make if the client's in pain, there will be an increase in blood pressure, pulse, and respirations. So again, there are physiological changes that occur in the body in response to pain. The pupils will dilate. There will be increased perspiration, or they'll become diaphoretic, and also increased muscle tension. The client may have their jaw clenched, their hands clenched. They'll actually muscle tension. When you lay your hand on their arm, you'll be able to feel how tense they are. And there may be altered GI motility. This altered GI motility may result in nausea and vomiting. Let's talk about pain, the different types of pain. We'll talk first about acute pain. Acute pain lasts anywhere from a split second up to 6 months. It's considered acute. And acute pain causes a decrease in healing and changes in vital signs. Again, these are the things you'll pick up with your assessments. Let's compare that with chronic pain. Chronic pain lasts 6 months or longer. It causes fatigue, depression, and immobility. These are like some of the patients that have long-term neuromuscular problems may have chronic pain with it. So let's talk about what you do, implementations the nurse should do for treatment of pain. Well, first of all, you want to establish a therapeutic relationship with the patient. There has to be a trust between the patient and the nurse for this to work. The nurse should establish a 24-hour profile. The nurse needs to know the location, the character, the intensity, the onset, the duration, and the precipitating factors for pain. All of these things should be part of the 24-hour profile. When does it happen? What brings it on? What type of pain is it? What relieves it? We also want to teach the client about pain. You know, what's going on, perhaps why they might be experiencing pain. It helps to reduce anxiety and fears. It will help increase the pain threshold and reduce the pain experienced by the client. We want to provide comfort measures. These can be things such as a good back rub, changing the bed linen, turning down the lights, providing soft music. But that doesn't take away the fact that many times we will administer analgesics. And with analgesics, there are several important concepts you need to know, both for your nursing care when you're out in the general public, and also for the Nclex. It's a good idea, or it's really essential, to use the preventative approach. If pain is expected to occur in a certain period of time, you should give them pain medication on a regular schedule rather than waiting for the patient to say, I'm having pain, I'm uncomfortable. Because in that case, then you've got to do something, it's harder to get them out of pain. So if pain is expected, you will give the pain medication kind of preemptively. Another way that we deal with pain is we use PCA, which is patient-controlled analgesic. This is a portable device that delivers pain med, and it's under the control of the patient. Let's now talk about some of the different types of trauma that can cause the patient to experience pain. The first type of musculoskeletal trauma we'll talk about are contusions. You remember that a contusion is an injury to soft tissue. You will see ecchymosis or bruising or a hematoma. The type of treatment you will do for a contusion is you will apply cold for 24 hours followed by heat. You might also apply an elastic bandage. Another type of musculoskeletal trauma is a sprain or a strain. Remember, this is a muscle pull. The patient will experience pain and swelling. The type of treatment you will do is you will put the patient at rest. You will elevate the extremity or the part that is strained or sprained, and you will again apply cold for 24 hours followed by heat. And again, you can apply an elastic bandage. Let's go on to another type of musculoskeletal trauma, which is a dislocation. Remember, dislocation is displacement of the joint surfaces. What the patient will experience is pain, and you will actually see a deformity. The treatment for a dislocation is you will immobilize and reduce. Again, immobilization and reduction of the displacement. A dislocation is an orthopedic emergency, and many times after the reduction they will bandage the area and then splint it. Let's go on, and you can see that our types of musculoskeletal trauma are getting worse and worse. Now we're going to talk about fractures and the emergency care you use for fractures. Remember, fracture is a break in the continuity of the bone. The type of symptoms you'll see for a fracture are there may be swelling, there may be deformity, the patient may complain of pain, there may be loss of function of that part of the body, and there may be crepitus. Remember, crepitus is the grating sound you hear when bone fragments rub on each other. Let's talk about the type of emergency care you do for fractures. First of all, you want to immobilize the joint above and below the site of the fracture. That prevents any type of movement, and hopefully you won't hear the crepitus. If the fracture is compound, you would cover any open fracture with the cleanest material available. Now, not many of us go around with a sterile pack in our back pocket. It might be a newspaper, it might be a blanket, something to cover it, to protect it. You will check color, temperature, sensation, and you will check for capillary refill distal to the fracture site. Again, these are all things that are done in the emergency setting. Let's now talk about what you do what the implementation is done for fractures outside of the emergency setting. Well, they will splint fractures. Again, we talked about that a little bit when we talked about emergency care. Splinting is done to immobilize the fracture to prevent movement. With fractures, they may be treated by what's known as internal fixation. These are the screws, plates, or nails that are used to stabilize the fracture. They may do open reduction. Now remember, open reduction is a surgical dissection that is used for reducing the fracture and aligning the pieces. Or they may do a closed reduction. Again, a closed reduction is just what it sounds like. They don't go in. It's not a surgical dissection. It is where they manipulate manually or provide traction to reduce the fracture. Now, fractures are a problem, and let's talk about some of the complications that can occur with fractures. The first complication, and again, is something we want to be on the lookout for, especially with the fracture of long bones, and that's that embolism. If your client suddenly becomes confused and they've had a fracture of a long bone, you should suspect that embolism. Another complication is what is called delayed union. With delayed union, it's just what it sounds like. There is slowed healing. Many times it's caused by infection or misalignment. Another complication is malunion, and it's just what it sounds like. Malunion or bad union. This is improper alignment. Non-union, again, is just what it sounds like. If you don't have healing 4 to 6 months after a fracture, this is considered non-union, and it's usually caused by a decrease in blood supply, stress to the site, or infection at the site. Another complication is sepsis. And this is a special complication if you've had a compound fracture that's open to the air. And the last complication is known as compartment syndrome. This is where there's pressure within a compartment. It can be caused by something external, for example, pressure from a cast, or it could be caused by bleeding into an area. But there's pressure in a compartment that compromises circulation, and it's called compartment syndrome. Now let's talk about some of the treatments they do for fractures. One of the treatments for fractures is they put the patients in traction. Let's talk about how traction works. Well, traction is used to reduce the fracture. It will also alleviate pain and muscle spasm. It will prevent or correct deformities, and it will promote healing. Let's talk about the two different types of traction. Now, you can have skin traction, where the pulling force is applied to the skin, just what it sounds like, or you can have skeletal traction, where the pulling force is applied to the bone. Let's take a look at some different types of traction. First of all, we'll talk about Bryant's traction. Bryant's traction is a type of skin traction. The legs are elevated at a 90-degree angle, and it's used with children 1 to 3 years old, less than 40 pounds. And you'll note that the buttocks must remain off the bed. What's happening in this case, with traction, you always need to provide counter traction. In this case, the child's body weight is the counter traction. For a child in Bryan's traction, again used in children less than 40 pounds, 1 to 3 years old, you will check the sensation in the feet. You'll check for toe motion, and you'll check for circulation. Let's talk about another type of skin traction, which is Buck's traction. Buck's traction is used both for fractures and for other orthopedic issues, and if the client in Buck's traction does not have a fracture, they may move side to side. If they have a fracture, they may not. With Buck's traction, usually 8 to 20 pounds of weight are used. And again, the weights hang off the bed. If Buck's traction is used for scoliosis, then 40 pounds are used. With Buck's traction, you will elevate the foot of the bed to provide for the counter traction. Because again, that will elevate it. You've got the traction weights on one side, the patient's body weight on the other for the counter traction. A patient in Buck's traction, you should use a trapeze to move themselves around in bed. And a pillow should be placed beneath the lower leg. Now, not the heel, because that would provide or promote a pressure area, but beneath the lower leg. And you do not elevate the knee gauge when a patient is having Buck's traction. Let's talk about a third type of skin traction, which is Russell traction. Now, with Russell's traction, again, you elevate the foot of the bed on shock blocks. This helps promote the counter traction. A client in Russell's traction, you will be checking the popliteal pulse. Again, you will put a pillow beneath the lower leg, but make sure the heel remains off the bed and off the pillow. When a client is in Russell's traction, they cannot turn from the leg down. From the waist down. Their waist and below has to remain stationary. They can only turn above the waist. Now, if you're moving a client in Russell's traction, you will lift the patient and not the leg. Now let's talk about a couple different types of skeletal traction. Cervical tongs are a type of skeletal traction, and usually there's always weight used with this. Again, the weights provide the traction, the patient's body provides the counter traction. It's imperative that you remember the weights are never lifted. There is no pillow under the head of a client with cervical tongs, and it is you need to pay particular attention to feeding this client because it's hard for them to swallow in this position. So safety is of paramount importance. Let's talk about another different type of traction used many times with skeletal traction, and that's known as balance suspension traction. With balance suspension traction, what we have here is the Thomas splint, which goes over the anterior thigh, and the Pearson attachment, which supports the leg from the knee down. Now, with balance suspension traction, you have weights kind of on both sides. Again, it's balanced and it's suspended. The client can move up and down all they want in bed. And again, a trapeze should be used to help them move up and down. Get on and off the fracture pan, change sheets, they pull up, you put the sheet under them. They cannot turn or twist. Let's talk about one last type of skeletal traction, and that's a halo jacket. They use a halo jacket preoperatively to help with scoliosis. Now, a halo jacket has pins into the cranial bones, and let's talk just a minute about care of pins. Many times the physician will order the pins to be cared for, and a half-strength solution of either peroxide or saline will be used with sterile swabs 1 to 2 times a day. So those are the different types of traction. The reason we use traction, again, you need to know about skin versus skeletal traction, and the type of tractions I talked about were the more commonly ones tested on the Nclex. This concludes Part 1 of Physiological Integrity 1, Basic Care and Comfort. Hello and welcome. I'm Judy Burkhart, National Director of the Nursing Programs for Kaplan, and welcome back to our discussion of Physiological Integrity 1, Basic Care and Comfort. Let us continue. Let's begin talking about casting and the immediate care after casting. Now, it's important for you to remember that casting is used for immobilization, and there are plaster cast or fiberglass cast. Let's take a look at the immediate care after casting. Well, the first thing that's very important for you to remember is not to cover the cast until it is dry. If it's a plaster cast, it will take about 48 hours to completely dry. While the cast is wet, you want to handle it with the palms of your hands, not your fingers. You don't want to leave fingerprints in anyone's cast. Another important consideration is you don't want to rest a cast on a hard surface because it will leave a dent while it is wet. You want to elevate the part that is casted above the level of the heart. This increases venous return and prevents venous congestion. So for example, if my right leg were casted, I would elevate my right leg above the level of the heart. And it's critically important that the nurse assess the pulses, the color, and the sensation distal to the casted part. Again, you're checking for any types of problems, changes in color, changes in sensation. Any complaints by the patient should be thoroughly investigated. Now let's talk about other things with intermediate care. Clients in casts need to keep muscle strength, and we talked earlier about the type of exercises they would use to do this. And remember, these were the isometric exercises, the alternate contraction and relaxation of a muscle. You can't move the joint, but you can contract and relax the muscle. With cast, during the intermediate section or section of time, you want to check for odors. The cast should not smell. And even though it sounds a little funny, you actually want to put your nose or teach the client to put their nose close to the cast and smell. Any unusual odors should be thoroughly investigated. And this is critically important for children. Make sure they know that they should not put anything down a cast. When my son was in a cast, when we took his cast off, we got $1.50 in change because he had developed a habit of seeing if he couldn't drop coins down the cast and have them go all the way through. So again, they need to know that this is something that will interfere and cause problems if anything is put under the cast. If a fiberglass cast is used and it becomes wet, it can be dried with a hair dryer on a cool setting. So that's one of the benefits for fiberglass casts. Let's talk about the after cast care. Someone's had a cast on for a period of time. When the cast is removed, what do you do? Well, first of all, you want to prepare the person for what the area is going to look like. It kind of resembles a mummy. I mean, the skin, there will be some sloughing of the tissue, and there may be some atrophy of the muscle. So prepare the client for what it will look like. You want to wash the area very gently. You might also apply baby powder or cornstarch. It's also important to elevate the limb. Again, this will help with venous return and reduce any congestion or swelling of the extremity. And sometimes elastic bandages are applied. It's important to let the client know that swelling is common after a cast is removed. And they again will help if they elevate the extremity and perhaps apply an elastic bandage. Let's now go from talking about cast care and casting and talk about a problem that's frequently tested on the Nclex, which is a fractured hip. If a client has a fractured hip, what will it look like? What assessments will you make? Well, first of all, many times the leg is shortened. It is adducted, remember add to midline, and it is externally rotated. Other symptoms you will see with a fractured hip is the patient may complain of pain. There may be a hematoma or area of ecchymosis at the site, which is bruising. Let's talk about what they do for fractured hips. Many times they will do a total hip replacement. And if a client has had a total hip replacement, what are the nursing responsibilities or implementations that you are responsible for? Well, first of all, you need to keep the leg abducted. Remember, abduct to take away. So you will probably put pillows between the legs to maintain the hip in a position of abduction. When the client gets up and begins ambulating, they will ambulate using crutch walking with a 3-point gait. Again, we talked about this before. Remember, this is a non-weight bearing type of crutch walking. Clients should be told that they are not to sleep on the operated side until instructed by the physician. They should not flex their hip more than 45 to 60 degrees. And the head of the bed should not be elevated any more than 45 degrees. So we could not put these patients in high Fowler's position. That would be too much of hip flexion. The danger here is, in some of the complications we're going to now talk about, is we don't want the prosthesis to displace. And again, the first complication after a total hip replacement that we want to prevent is dislocation of the prosthesis. Remember, the hip is a ball and socket joint. We don't want to put any traction and pull that prosthesis out of place. Another complication is excessive wound drainage. And again, we'll monitor the type of drainage that happens. Thromboembolism can occur, and again, we want to make sure the client is, doing the type of exercises that they should do to prevent this complication. And infection is, again, a possible complication because the total hip replacement is an invasive procedure. Now let's talk about what we'll teach our clients going home, because they will go home after a total hip replacement. Well, we will teach them to do the same thing at home we've been doing in the hospital, and that's to maintain abduction. And they should know what that means, and again, use the term, tell them what it is, and tell them how to do it. And they should know why it's critically important, because this will prevent the dislocation of the prosthesis. They should also be taught to avoid stooping. They should not sleep on their operated side until the physician tells them that they can. They can only flex their hip to about 1/4 of a circle. They should not cross their legs. Again, that would put too much traction on the prosthesis and could cause dislocation. And they can resume their activities of daily living, or ADLs, in about 3 months. And it's good for these patients to know that walking is a good exercise. Again, but they should stop when they get fatigued or short of breath. Let's now change gears a little bit, and we're going to talk about some rest and sleep disturbances. First of all, let's talk about hospitalized patients. Rest and sleep, I remember there's many jokes you hear in nursing school about the fact if you want to get rest or go to sleep, don't go to the hospital. They will bother you incessantly. And let's talk about some of the things that will help promote rest and sleep for a patient that is hospitalized. First of all, it's important to get information from the client about what their sleep pattern is normally. What time they usually go to bed, what time they usually get up, whether or not they get up during the night to use the bathroom or, read or whatever. But you need to know what is, quote, normal for these patients. Another important issue, and one that I think sometimes we forget, is we should give care in blocks of time. We should not constantly be in the room, especially if the patient is trying to rest or to sleep. We want to avoid any unnecessary lights or noise. And this is important, and again, this is also frequently tested. Pain medication is preferable to sleeping medication. Remember, sleep medication interfere with the REM stage of sleep, where pain medication does not. So if the patient is going to be going to sleep, again, if pain might be an issue, you would give pain medication rather than a sleeping aid. It's important to provide diversional activities for these clients so they do some activity during the day so they are more tired at night, and then they will go to sleep. And it's very important to let them know what's going to be happening in the hospital environment. Let them know the type of things that they can expect to see and undergo while they are hospitalized. Now, one of the issues with rest and sleep is the elderly. Elderly patients many times have difficulty going to sleep. They may wake early in the AM. They may have brief periods of wakefulness during the night. Or, there may be some changes in their sleep cycle. Let's talk about things we can do for both hospitalized and elderly patients or clients at home to help them with their rest and sleep. Well, first of all, it's important for them to establish a regular schedule of sleeping. What that means is go to bed about the same time every night and wake up about the same time. That will help the body get into a certain cycle, and again, it will help promote the circadian rhythms that go on. It's important and helpful if they avoid caffeinated beverages in the evening. Remember, these are things such as caffeinated coffee, tea, colas, that type of thing. Chocolate. Chocolate before bed contains caffeine, and again, it may interfere with the sleep cycle. It's also helpful to establish a bedtime ritual. These may be things such as a warm bath, having warm milk and a few cookies, not chocolate ones, but vanilla cookies before bed. And it also helps if the elderly clients exercise regularly. Again, this promotes good circulation, and again, it may make them more tired so that they will sleep better at night. Now, there's one issue that, again, happens especially with men, older, overweight men, and that's known as sleep apnea syndrome. And let's take a look at that right now, what you will see with sleep apnea syndrome. And again, this is usually an overweight, older man. These clients snore loudly, then many times they will stop breathing for about 10 seconds or more, and then they awaken with a loud snort. And many times the significant other of these men complain about the snoring and the noise. How can I sleep? You are making a racket all night long. These clients with sleep apnea syndrome many times complain of daytime sleepiness. they say, well, I'm tired too. I don't know why both of us are, tired during the day. Well, it's because this person really isn't getting very good quality sleep at night. They may also complain of a morning headache. They may also complain of a sore throat, because many times they sleep with their mouth open. And there may be personality or behavioral changes. So let's take a look at what is done, or the implementation for sleep apnea syndrome. Well, one of the important things and first things is these clients should avoid the intake of alcohol. They should reduce their weight, because sometimes that in and of itself will help. If the sleep apnea syndrome continues to be a problem, the physician may order continuous positive airway pressure, or CPAP. The physician might also order bi-level positive airway pressure, or BiPAP. And they may also do surgery to correct whatever obstruction is there. Okay, let's change to another topic now. Let's talk a little bit about Alzheimer's disease. Now, Alzheimer's disease, remember, is a progressive, irreversible, degenerative neurological disease. Let's take a look at what you'll see with Alzheimer's. Patients with Alzheimer's, they start with forgetfulness. It's small things at first and then it builds up. There may be some paranoia that they experience. They will develop a very short attention span. They get agitated very easily and very frequently. They may engage in what is known as night wandering. They get up in the middle of the night and wander around. They may actually leave the house. And incontinence becomes a problem. Let's take a look at what you do for Alzheimer's disease. The implementation for Alzheimer's disease, well, first of all, you want to place this client in a calm, predictable environment. What that means is if an Alzheimer's patient is suddenly hospitalized in an acute care setting, you need to make sure that they are oriented to the surroundings and the environment remains calm and predictable so they know exactly what is going to be going on. Again, a regular routine is important for these clients. So they know, don't move furniture in the house of a client with Alzheimer's. Don't change the routine. If you have a sitter that comes in during the day and she can't come today or he can't come today, their friend is going to come instead. That type of break-in routine could cause agitation in the Alzheimer's client. You need to secure the doors leading from the house with some type of implement. Now again, safety is an issue here. You don't want to lock anyone in a house in the event of a fire or some type of catastrophe they can't get out. But you need some kind of alarm system or something so that the Alzheimer's patient can't wander away during the night. You wake up, they're gone. They may have walked 3 or 4 miles down a very busy road. You want to gently distract and redirect their wandering behaviors. Again, that's how you would deal with the wandering behaviors. You might say, well, let's just restrain them. No, you want to avoid restraints because a couple of reasons. One is they increase combativeness. Also, it's not something that should be done with these clients. It's a last resort with these clients. And many times the Alzheimer's patient will do well if you provide a list and very simple instructions. Other things you should do with Alzheimer's clients is you want to make sure they have good nutrition. And you want to promote independence. Keep them as independent as possible for as long as possible. Okay, let's talk now about some thyroid problems. The first thing we're going to talk about with thyroid problems is hypothyroidism or myxedema. Remember, hypothyroidism is due to a hyposecretion of the thyroid hormone. Let's talk about the assessment or what you would see for a client with hypothyroidism. Well, usually they have a decreased activity level. They really are just kind of in slow motion, if you will. They become very sensitive to cold. These clients also experience weight gain and bradycardia and constipation. So you can see that because the thyroid regulates metabolic rate, the whole system slows down. Let's talk about what you do, implementations you do for thyroid disorders. And again, we're going to be talking about hypothyroidism. Well, first of all, and it makes sense, you would provide for hormone replacement. Medications such as Synthroid are used. You would want to pace activities for these clients and provide frequent rest periods. You would restrict the use of soap because they usually experience dry skin. Because they're very sensitive to cold, you would provide extra clothing. Again, you would provide small frequent feedings, again, and you might cut back a little bit with the caloric amount because of the weight gain. But you would want to make sure that they have a good fluid intake. The type of diet clients with hypothyroidism usually go on are a high fiber diet. Again, this helps with the constipation. Well, let's look at the other side of the coin now, someone that has too much thyroid hormone. This is hypersecretion of the thyroid hormone, or hyperthyroidism, also known as Graves' disease. What you would see for a client with Graves' disease or hyperthyroidism is they will be hyperactive. And again, it makes sense. If the thyroid hormone regulates your metabolic rate and there's too much of it, you are in overdrive. So you are hyperactive. These clients will complain of sensitivity to heat. They are always warm. They will experience weight loss because of the high metabolic rate. They will have tachycardia, again because of the high metabolic rate. They will have diarrhea because of the increase in the peristalsis in the GI tract. They will have exophthalmosis, which is the bulging of the eyes, and they will be nervous and jittery. So you can see that it's kind of the exact opposite of the patient with hypothyroidism. Let's talk about the implementations you do for Graves' disease or hyperthyroidism. Again, the type of medications, it makes sense you would use an antithyroid medication. These are medications such as Tapazole or SSKI, saturated solution of potassium iodide. They may also use irradiation with the I-131 to actually decrease the activity of the thyroid gland. They may do surgery, and the type of surgery they would do would be a thyroidectomy. For these clients, you want to provide frequent rest periods. You would avoid stimulants. They have all the stimulation they need. In fact, they need a quiet, restful environment. You should engage them in quiet activities, and they should wear light clothing. Again, remember we said that they were very sensitive to heat. They're always warm. Light clothing, again, cotton clothing that breathes. Now, one of the things with hyperthyroidism we want to talk about is the patients can go into thyroid storm. And let's talk about thyroid storm. With thyroid storm, what you will see under assessment is the patient will have an abrupt onset of congestive heart failure. They will experience delirium, and they may have altered clotting. So let's talk about what you do for thyroid storm. Well, implementation for thyroid storm is you would provide a hypothermia blanket because, again, the temperature will increase. They will be febrile. You will provide oxygen for these clients, and the medications used are potassium iodine, PTU, digitalis to help prevent any congestive heart failure, Indirol, hydrocortisone, which is an anti-inflammatory, and Tylenol, which is an analgesic. Those are the type of thyroid disorders that are frequently tested on the Nclex. Let's now talk about the parathyroid disorders that you may see on the Nclex. The first parathyroid disorder we're going to talk about is hypoparathyroidism. Again, this is due to not enough secretion of not enough secretion of the parathyroid hormone. Let's talk about what you will see. The first symptom you'll see is tetany. And one of the ways you'll check for tetany is you will see a positive Chopstek sign. Remember, Chopstek sign is when you tap on the facial nerve and there's facial twitching. If you do that, that indicates that there is tetany. Another thing that you will check is you will check Trousseau's sign. This is where you inflate a blood pressure cuff on the arm to 20 millimeters of mercury above the systolic blood pressure. If the patient experiences carpal spasms, that's spasms of the hand, in 2 to 5 minutes, that indicates that they have tetany. Now, some students say, I can't remember how each of these signs. Well, I remember Trousseau's sign because when you pack your trousseau, you put in a blood pressure cuff. So I remember that's the one that involves a blood pressure cuff. And again, you should know that positive Chopstek sign and positive Trousseau sign indicate tetany, which is seen with hypoparathyroidism. The other symptom that patients may experience is muscular irritability. Let's talk about what you should do or the implementation for hypoparathyroidism. Well, the medication that's used is calcium lactate IV. Vitamin D is also administered along with elemental calcium. Usually these patients are put on a low phosphorus, high calcium diet. Okay, let's talk about the other side of the coin. Let's talk about patients with hyperparathyroidism. What you will see under assessment for hyperparathyroidism, the patients will have muscle weakness. They may have cardiac dysrhythmias. They may experience renal calculi, and they may develop pathological fractures. Let's talk about what you will do, the implementation for hyperparathyroidism. Well, one of the first things you'll do is increase the patient's fluid intake. Remember, normal fluid intake is 2,000 cc's. So if we're increasing fluid intake, we would increase it to 3,000. We will put this patient, or the physician will put this patient, on an acid-ash diet. The reason they do this is it increases the solubility of calcium. Another thing the nurse should do is monitor the patient's potassium levels. Remember, potassium counteracts the effects. Let me start again. Potassium counteracts the effects of calcium on the cardiac muscle. And many times IV Lasix and saline are given because they promote calcium excretion. So those are the hypo and hyperparathyroid disorders that are frequently tested on the Nclex. Let's change gears a little bit here, and we're going to begin talking about nutrition. When you talk about nutrition, again, this is something that kind of underlies many of the questions you will see on the Nclex exam. Let's talk about what the components of nutrition are. When you think about nutrition, the first thing that comes to mind for many of us is carbohydrates. You'll remember that carbohydrates are the first source used for energy production, and it is the only source of energy used for energy production in the brain. So if you don't have carbohydrates, your brain doesn't function very well. The second type of thing when you talk about nutrition are fats. This is the second source of energy production. But when you break down fats, you need to remember that waste products known as ketone bodies are produced, and if they accumulate, the body becomes very acidic. Going forward with nutrition, the next thing that we deal with nutrition are proteins. These are the last source of energy production, the last source of energy used for production. If you deplete your proteins, that will lead to muscle wasting and loss of oncotic pressure, and this will interfere with your fluid and electrolyte balance in the body. So protein balance is critically important. The next thing we'll talk about are vitamins. Remember that vitamins are organic substances found in food. They are essential in small quantities for normal growth to take place. And let's talk about vitamins. When you think of vitamins, you'll remember that there are fat-soluble vitamins and water-soluble vitamins. Let's talk first about fat-soluble vitamins. Vitamin A, and your fat-soluble vitamins are A, D, E, and K. And the way I remember this is I remember the fat-soluble, I know everything else has to be water-soluble. Vitamin A is used or essential for visual acuity. Vitamin D, again a fat-soluble vitamin, deals with calcification in bones and the absorption of calcium and phosphorus. Vitamin E, third fat-soluble vitamin, is an antioxidant. And vitamin K is essential for normal blood clotting. Let's now talk about the water-soluble vitamins. And again, remember, these are all the ones that are not A, D, E, or K. We'll start first with thiamine, or B1. Thiamine is essential for normal carbohydrate metabolism. And when we talked about the patient with alcoholism, we talked about the need for thiamine to be administered so normal carbohydrate metabolism can take place. The next water-soluble vitamin we'll talk about is pyridoxine, or B6. This is necessary for the amino acid metabolism. Folic acid is the third water-soluble vitamin. It is essential for red blood cell formation. And cyanocobalamin, or vitamin B12, is essential for nerve function. We've talked about vitamins, let's now talk about minerals. With minerals, again, they're essential in small quantities. An important mineral, one we've talked about kind of off and on through these sessions that we've had, is calcium. Remember, calcium is essential for bone formation and muscle contraction. Another mineral we need is sodium. We talked about this when we talked about fluid and electrolyte balance. Critically important for acid-base balance. The next mineral is potassium. Again, we talked about this when we discussed fluid and electrolytes. It's essential for protein synthesis and normal heart contractility. And iron is essential for hemoglobin synthesis. Now, when we're talking about nutrition, one of the things that is frequently tested on the Nclex exam are what is known as therapeutic diets. And let's talk about some of the more common therapeutic diets you may see tested. First one is a clear liquid diet. This type of diet is used to maintain fluid balance. Usually post-op patients are started on a clear liquid diet. Remember, a clear liquid diet is anything you can see through. For example, apple juice is clear liquid. A full liquid diet is nutrition without swallowing. Now, a full liquid diet is anything that's liquid at room temperature. And they kind of get a little odd here because things such as oatmeal is on a full liquid diet, and it's not exactly liquid at room temperature, but it is included on a full liquid diet. The third type of therapeutic diet is a low-fat, cholesterol-restricted diet. This type of diet reduces the calories from fats and limits the cholesterol intake. Many people in the United States, because we have such a high fat intake, the physicians put them, or they put themselves on a low-fat, cholesterol-restricted diet. A sodium-restricted diet. Patients with congestive heart failure and some cardiac diseases and problems will be put on a sodium-restricted diet. This lowers the amount of body water that's held, because remember, where the sodium goes, the water stays. The next type of diet we'll talk about is a high roughage, high fiber diet. This type of diet is used to maximize the bulk of the stools. So a patient that's having difficulty with constipation might be put on a high roughage, high fiber diet. The last type of diet is a low residue diet. A low residue diet is used to minimize intestinal activity. For example, someone after surgery might be put on a low residue diet because they don't want the GI tract to work very hard. Okay, let's talk about a couple more therapeutic diets. A high protein diet. A high protein diet is used to reestablish anabolism, or that's buildup of tissue, to raise albumin levels. Again, we talked about protein is essential to maintain the oncotic pressure. Some patients have difficulty with that. We'll put them on a high protein diet to reestablish the buildup of the body. A renal diet. A renal diet is used, it keeps protein, potassium, and sodium low. That's the type of diet a patient with renal disease will be put on. Again, limitations sometimes in protein, potassium, and sodium. Another type of diet is a low phenylalanine. This prevents brain damage from an imbalance of amino acids, and patients with PKU are put on this type of diet. Now, we've talked about the different types of therapeutic diets. Let's talk a little bit about the cultural issues surrounding nutrition. There are cultural food patterns, and sometimes this is tested on the Nclex. And again, they won't choose an obscure culture. It will be a culture that is commonly found. The first type of cultural food pattern we'll talk about are those that are experienced or are done by Orthodox Jews. This is called a kosher diet. And the rule here is that meat and milk cannot be eaten at the same meal or on the same dishes or utensils. Again, this is a kosher diet. Muslim diet. Muslim individuals engage in a 30-day fast during a feast of Ramadan. Japanese diet. You'll remember if you've eaten in a Japanese restaurant, or you're Japanese or have Japanese friends, that rice is one of their basic foods and tea is their main beverage. And a Greek diet, you'll note that bread is served with every meal. So that's a little bit about the cultural components that go along with nutrition. Now let's talk about nutrition as we go through the lifespan. What type of changes are necessary? What type of things should we be assessing? And we're going to start with the premature infant nutrition. A premature infant needs about 100 to 200 calories per kilogram per day. Let me say that again. A premature infant needs 100 to 200 calories per kilogram per day. Premature infants also need higher sodium, calcium, and protein than a full-term infant. Their requirements are higher. Okay, let's now look at a full-term infant. A full-term infant needs 120 calories per kilogram per day. You would expect a full-term infant to have between 6 and 8 wet diapers every day and about 1 stool. Breastfeeding many times is used for nutrition for a full-term infant, and many times the mother will engage in this activity for between 6 to 12 months. If the child is formula fed, if cow's milk is used, it is diluted to reduce the protein content, and sugar is added to increase the carbohydrate content. Again, if a formula feeding infant, cow's milk is diluted, again brings down the protein content, and sugar is added to increase the carbohydrates. Let's talk a little bit more about full-term infant nutrition. At 1 to 4 months, the child may begin taking liquid vitamins. 4 to 5 months. During this time, many times rice cereal is introduced and strained fruit. Between 5 and 6 months, the child may be started on vegetables and strained meat. And 7 to 9 months, The child may be started on chopped meat and finger foods. So this is the way that the different types of foods are introduced in addition to the breastfeeding or the formula. Let's go on to the toddler phase. Now when you think of toddlers, one of the things you should think about are the terrible twos that happen during this period of time. What the parent should be told is to avoid struggles over eating. You need to pick your battles. It's kind of like the same with adolescents. You don't want to fight over eating. You need to provide good foods and safe foods for your child, but don't fight over the fact that they haven't eaten this or won't eat that. The toddler needs fewer calories but more protein and calcium than an infant. So it's important that we provide less calories but more protein and calcium. And this is difficult because during this time they want the calories and the sweet things rather than the protein. Let's go on to the preschool age, preschool and schooler. During preschooler and school age, during this time the growth rate will slow, but the protein and calcium needs remain high. Let's go on to adolescence. Again, you might get a little bit of negative feedback during this period of time, but calorie, calcium, and protein needs remain high. Again, remember this is a very rapid period of growth. Females during this period of time need iron due to menstrual losses, and for both females and males, mineral and vitamin needs remain high. Let's go on into the adult and elderly population. What are their nutrition needs? Well, during this time there is a reduction in the need for calories, and because many people continue to eat the same type of thing they always ate, this is why many adult and elderly clients gain weight, because they don't reduce their caloric intake. But it's important that although the need for calories is reduced, they need the same level of minerals and vitamins. And an important component is, again, with postmenopausal women, you need to prevent osteoporosis. Let's talk about nutrition during pregnancy. It's important that you know that the recommended weight gain during pregnancy is 24 to 28 pounds. And during pregnancy, the recommended diet, it's a normal diet plus about 300 calories per day to account for the growing fetus and the needs there. Let's talk about nutrition during lactation. During lactation, the client should eat a good balanced diet and add about 500 calories per day, again, to meet the needs during lactation. Let's talk about the nutrition for a couple of high risk, or the nutritional needs for some high risk pregnancies. First of all, if you have an adolescent that's pregnant, what are the nutritional needs? Well, one of the things that's important to remember is you need to meet the mother's needs in addition to the developing fetus's needs. So they need high protein, high calcium. And it's important that you remember that adolescents tend to deliver low birth weight babies. So it's critically important that we address both the baby and the adolescent mother's nutritional needs. Let's talk about the nutritional needs for another type of high-risk pregnancy, and that's the women that are diabetics. If a woman's a diabetic and pregnant, you need to monitor her glucose level very closely. These women tend to deliver post-mature babies, meaning older babies. This woman may need a cesarean section due to the glucose requirements of labor. She may not be able to meet those, so a cesarean section would be scheduled. Let's go on and talk about another high-risk population, and that's women that have sickle cell and are pregnant. Many times they will do a cesarean section with a mother who's pregnant with and has sickle cell because of the oxygenation requirements of the mother during labor. She may not be able to meet those requirements, so they will schedule a cesarean section instead of having her go through labor. Let's talk about the nutritional needs again for another type of high-risk pregnancy, and that's a woman that has cardiac issues. These women may need to decrease their activity, and again, they may need a cesarean section to decrease the demands on the mother's heart. She may not be able to tolerate the stress of labor. Let's change gears a little bit here, and we're going to begin talking about enteral feedings, the type of things that we do and the type of complications you can see. With enteral feedings, let's start with the complications. Remember, this is where we provide nutrients either through a tube, Salem sump, Levine tube, some tube such as that. Now, the first complication we're going to look at is tube displacement. If the Salem sump tube comes out or the Levine tube comes out, you will replace the tube. Another complication that you may see with tube feedings, and this one you want to prevent because it's a whole lot easier to prevent than it is to do the treatment for it, is aspiration. If a client is undergoing a tube feeding, you need to elevate the head of the bed. And the head of the bed should be elevated even for half an hour or so after the feeding has been completed. And if you are giving tube feedings, you need to check for residual before each feeding. If they're intermittent, you will check intermittently. If they are continuous, you will check continuously. Again, if there's too much residual left, you know the stomach is not emptying. And if you continue to give the patient more feeding, it will extend the stomach and the person has a great danger of aspiration. Let's go on and talk about some additional complications of tube feeding. One is cramping, vomiting, and diarrhea. If your patient that's undergoing tube feeding or enteral feeding has these type of problems, several things you can do. One is you may need to decrease the rate of the feeding. It's too fast. The body is unable to absorb it at the rate that it's going. Or the formula may need to be changed. Usually when enteral feedings are started, they don't start with full strength Ensure, for example. They would start with half strength or quarter strength and then kind of build it up. Start with half strength, then 3/4 strength, and then full strength. So the body gets used to or gets accustomed to the type of feeding that's being done. So it may be necessary to change the type of feeding or change the formula. It's important that you give the feeding at room temperature. Now many times these feedings are stored in the refrigerator, so you want to warm them before they're administered to the patient. I don't know if you've ever drank something very cold and your stomach kind of, you kind of get cramps and you may, vomit. It's because of the cold in the stomach is irritating. Let's talk about another complication that may be experienced by a patient who's receiving enteral feedings, and that's glucose intolerance. It's important if a patient's getting an enteral feeding for the nurse to monitor the glucose and the serum osmolarity. These are hypertonic solutions that are given in the enteral feeding. It may be necessary if the glucose goes up, the patient becomes hyperglycemic, to give insulin. And the type of insulin that is usually used is regular insulin. Or the rate of infusion may need to be changed. Okay, let's take a look at total parenteral nutrition, also known as TPN. If you are giving total parenteral nutrition to a client, there's several things you need to know. And again, this is a frequently tested topic on the Nclex. Well, first of all, when they start TPN, the initial rate is usually 50 milliliters per hour. And they will increase it to 100 to 125 milliliters per hour as tolerated by the patient. TPN is given using a pump. Now, if the rate is too fast, if there's too fast a rate, the patient will go into what we call a hyperosmolar state. And you will know this because the patient will experience headache, nausea, fever, chills, and malaise. So again, you wouldn't suddenly go from 50 to 125 because this increased rate would cause a hyperosmolar state. But by the same token, you wouldn't suddenly decrease the rate. You wouldn't go from 125 back to 50. Because if you suddenly reduce the rate of the TPN, there may be rebound hypoglycemia. Again, remember, the body's gotten very used to the solute load and the amount of glucose being delivered. And if you suddenly reduce that or take it away, there can be hypoglycemia. You will know this because the patient will experience confusion. They may have tremors. They may become hypotensive. They will develop tachycardia. And they will have cool, clammy skin. Now, you may say to yourself, now, wait a minute, those are signs of hypoglycemia. Absolutely. Just because the hypoglycemia is caused by a change in the rate of TPN infusion doesn't mean the symptoms will be any different. So learning the symptoms here will help you use them when, for example, you have a diabetic patient that becomes hypoglycemic. Let's talk about some complications you may see with TPN. And we've alluded to some of these, but we're going to go in a little bit greater depth. The first one is sepsis. Because this is an invasive procedure, there's a danger of infection. What you want to do to prevent sepsis is you want to maintain a closed system, tape all connections. You do not draw blood through the TPN line, and you use a dry, sterile, occlusive dressing over the site. Again, this will help keep out any pathogens. Another complication for TPN is pneumothorax.
because they put the line in, many times we use a central line, there is a danger that they will disrupt the negative pressure of the lungs. What you do with this, or you will know this again, the signs of pneumothorax will be there. The patient will become short of breath with altered breath sounds. After a TPN line is inserted, you will only start feeding after X-ray verifies the placement of the line. So again, because pneumothorax is a possible complication. Let's talk more about some of the complications you may see with TPN. The next one I'm going to talk about is frequently tested. This is hyperosmolar coma. What happens here again, if the solute load is too high, there's a problem. And you're going to know this because you are going to be monitoring the client's glucose level and serum osmolarity. You may also be monitoring the urine for glucose and acetone. So again, this is something that can happen, and you're going to monitor to make sure that this doesn't occur with your client. Let's talk about some of the nursing considerations or things you will do for a client that is receiving TPN. Well, first of all, you want to change the IV tubing and filter every 24 hours. Remember, we said that sepsis can be a complication, and we don't want the patient to develop infection. So we'll change the IV tubing and filter every 24 hours. The solutions will be refrigerated, but they should be warm to room temperature before they are used. Because again, we talked about infusing cold solutions could cause cramping, diarrhea, and problems with the patients. So you want to warm the solutions to room temperature. If a new solution is unavailable, what do you do? And again, this is a frequently tested topic on the Nclex. The patients have a TPN, but suddenly the next container is not available. You will use a 10% dextrose and water solution. You'll use this because this also is a hypertonic solution, because you don't want suddenly to reduce the tonicity of the fluids that you're giving to the patient. Let's talk about some other nursing considerations. Daily you will check the patient's weight. You will check glucose more often than daily. You will check temperature, and this patient will be on intake and output. You will check 3 times a week. You will check the BUN to see if it's changing. You will check electrolytes, and especially you're looking at calcium and magnesium and perhaps potassium. Once a week, you will check the CBC or complete blood count. You will check platelets. You will check prothrombin time or PT. You will check liver function tests, and these are the AST, ALT, and you will check serum albumin. Because it's important to continually monitor this client because of the type of treatment they're undergoing. Now, when TPN is discontinued, what type of activities need to take place? Well, first of all, and I'm sure you know what I'm going to talk about now, we're going to gradually taper this solution because the client needs to gradually adjust to the decrease in glucose level. We don't want them to undergo or experience rebound hypoglycemia. And you will provide an isotonic glucose solution to prevent rebound hypoglycemia. That concludes our discussion about nutrition. Let's begin talking about elimination and some of the issues concerning elimination you may see on the Nclex exam. Well, first of all, we want to promote normal urinary elimination with our clients. Let's take a look at what that is. To have normal elimination, you need something to work with, which means you need an adequate intake. A normal intake is 1,500 to 2,000 cc's per day. Clients, to promote normal urinary elimination, should avoid diuretics, and caffeine is a good example of a naturally seen diuretic. If you have the urge to void or to urinate or to pass water or whatever terminology your client use, they should be taught to immediately respond to the call. If they don't, the urine will become static in the bladder, and it sets up a possible focus of infection, and they'll end up with a urinary tract infection. And clients that have catheters, especially if they've had a catheter for some time, you shouldn't go in after 2 weeks and say, whoop, we're going to take the catheter out today. You need to clamp that catheter to get the stretch mechanism in the bladder used to working again. Otherwise, the patient may experience either incontinence or retention. Okay, let's talk about some other ways that we promote normal urinary elimination. One is Kegel exercises. You remember these are exercises that are done to strengthen the pelvic floor. They're done after delivery. They are done with women as they go post-menopausal. The type of things you do with Kegel exercises, remember, you tighten the muscles in the pelvic floor for a count of 3 and then relax for a count of 3. Another way we can promote normal urinary elimination is with what we call triggering techniques. These are things such as stroking the medial aspect of the thigh, pulling on the pubic hair, or digital anal stimulation. These are things that are used with patients, for example, with spinal cord injuries that don't have the normal triggering techniques and may not be able to respond to the urge to void. Another way we can promote urinary elimination with clients is using intermittent catheterization. With this type of things, we intermittently catheterize the patient. It may be done every 2 to 3 hours after the patient attempts to void. If, when we do the intermittent catheterization, there is less than 150 cc's or milliliters, then you would extend the time from every 2 to 3 hours to every 3 to 4 hours. And then again, if when you did the intermittent catheterization there was less than 150 cc's, you would extend the time to every 4 to 6 hours. Now, you don't extend any farther than every 8 hours, because everyone would need their bladder emptied every 8 hours. Another way or thing we can do to promote urinary elimination is to put some patients, especially the elderly, on a toileting schedule. This is especially helpful for patients in long-term facilities. You would toilet them first thing in the morning and then every 4 to 6 hours on a regular basis. And the last thing is bladder retraining, and we talked a little bit about this when we talked about clamping catheters prior to removal. When we talk about elimination, one of the things that comes to mind early is the toilet training that we do with children. One of the important things, again, in a frequently tested question is, when should toilet training begin? And the correct answer here is after 18 months of age. You need to make sure that the child is physiologically ready and has the ability for sphincter control before you begin it. If you have training or what you think is training before that time, chances are very good mom or dad is trained, not the child. By the age of 3 years, the child should have regular voiding habits, and by 5 years of age, they should have nighttime control. There's some exceptions to this, and sometimes enuresis or bedwetting is a problem a little bit longer. But usually by 5 years of age, most children are dry during the night. Let's go from urinary elimination and begin talking a little bit about bowel elimination. What we can do to promote bowel elimination. Well, one of the first things, and we talked a little bit about this earlier, is you need to provide the time and privacy for normal bowel elimination. Again, many times the position, it's hard to defecate unless you can use gravity and push down and bear down. Also, adequate fluid intake is necessary to keep the stool in a semi-soft or soft consistency. If it becomes rock hard and concrete-like, it becomes very difficult to pass. The type of diet that will help with bowel elimination is a diet high in fiber, with lots of fruits, vegetables, and grains. And this is especially important with the clients as they get older, with elderly clients. And exercise is important. It stimulates peristalsis and stimulates normal bowel evacuation. Let's go from bowel elimination, talk a little bit about renal and ureteral calculi. If a patient has renal or ureteral calculi, what you will see, they will have they will experience pain. And on a 1 to 10 scale, this pain may be 11.5. This is serious, severe pain that they experience. They also become diaphoretic. They may have fever and chills. They may have hematuria. Remember, hematuria is blood in the urine. Ureteral or renal calculi can be caused by hypercalcemia. Again, the calcium precipitates out. It can be caused by dehydration because, again, there's not enough fluid there and things will precipitate. And it can also be caused by immobility. Remember, when the client's immobile, calcium leaves the bone and can cause renal calculi. Good reason why we want to get people up and moving quickly. If a client experiences renal calculi, what do we do? Well, one of the things we'll be doing is monitoring their intake and output. We will strain all urine. And it's important to remember, we're not looking for a boulder here. We're looking for small pieces of what looks like a rock or a pebble or a grain of sand. Remember, the ureters and the urethra is not very big, so you wouldn't be looking for something an inch in diameter. Any type of voiding they do, you want to check the pH. We will force fluids with these clients. Again, we will force fluids to 3,000 cc's. Dietary changes may be necessary. Again, when you get the stone, if it is passed, You would examine it, or would be examined, and it would be found what type of stone it is, and then the diet would be changed to prevent the development of that type of stone. Sometimes the stones don't pass, and then they use things such as extracorporeal shock wave therapy. This is where they use shock waves to break apart the stone. They might also do surgery. And some of the type of surgeries they can do is a nephrostomy or a pyelolithotomy, to actually go in and they'll remove the stone. Let's go on now and talk about another complication or another disorder involving the urinary tract, and that's cystitis. Many of us have had cystitis somewhere along the line. It's kind of a problem of nursing many times because we don't respond to the call because we get very busy. The type of assessment or symptoms you will see with cystitis: there will be urgency, there will be frequently, and there will be burning on urination. It will probably raise you right up off that toilet seat. Let's take a look at the implementation you'll see for cystitis. You want to force fluids. Again, remember, to 3,000 cc's per day. It is helpful to acidify the urine, and juices such as cranberry juice do this. Orange juice, remember, does not. Antibiotics are prescribed, such as Septra. A couple of things. For women, it's helpful to teach them to void both before and after intercourse. This helps prevent the development of cystitis. And again, it's helpful to teach, especially women, proper cleaning after defecation. You wipe from the front to the back. Let's talk about another urinary tract problem, and this is pyelonephritis. What you will see if a client develops pyelonephritis is they will experience chills and fever. They will have flank pain. And it's important for you to remember that pyelonephritis is caused by E. coli. It can be caused by an extension of a urinary tract infection, can be caused by pregnancy, tumor, or obstruction of the system. Well, what do you do for pyelonephritis? The patient will be put on bed rest, and antibiotics will be ordered. And you'll note that each type of urinary problem I'm talking about gets more significant and worse and worse and worse. Okay, the next one we're going to talk about is glomerulonephritis. With glomerulonephritis, what you will see: the patient will experience fever and chills. They will have hematuria, again, blood in the urine. They will have proteinuria, which is protein in the urine. They will experience edema. They will become hypertensive. And they will have abdominal or flank pain. Now, it's important for you to remember that glomerulonephritis many times occurs about 21 days after the patient has experienced a beta hemolytic streptococcal infection, usually of the skin or of the throat. Again, this is a frequently tested issue on Nclex. You need to know the relationship with beta hemolytic strep and the later development, 21 days later, of glomerulonephritis. Let's take a look at what you do for implementations for glomerulonephritis. They will put the patients on antibiotics and corticosteroids. The antibiotics will deal with the infection. The corticosteroids will deal with the inflammation. They will also put the patient on antihypertensives and immunosuppressive agents. The antihypertensives will help with the hypertensions, and the immunosuppressive agents will help with the immunological issues going on. You will restrict the patient's sodium and water intake. This patient will be on bed rest. You will be monitoring intake and output in addition to daily weight, and they will be put on a high-calorie, low-protein diet. Again, high-calorie, low-protein for the treatment of glomerulonephritis. Let's go on now and talk about prostatic hypertrophy. What will you see with prostatic hypertrophy? This happens with men, and they will complain of hesitancy, meaning it's difficult for them to start their urinary stream. They will complain of frequency. They will have urgency. They will have dysuria or pain on urination, and they have nocturia. And many times it's the nocturia that brings the patient to the hospital or the client to the hospital. They get up 2, 3, 4 times a night, and they are tired in the morning because they've been up going to and from the bathroom all night long. Let's take a look at the implementation you'll do for prostatic hypertrophy. Well, they many times will do a prostatectomy. And after a prostatectomy, the patient will usually come back with a continuous bladder irrigation, or CBI, running. Remember, this is sterile normal saline that is used. And when a patient has a CBI, you want to make sure and note or keep track of how much CBI is infused, so when you get the output, you can subtract it to know how much was actually urinary output, because you'll have like huge numbers of output, and you need to subtract the CBI from output to know how much the client actually voided or how much was urine. And you need to let the patients know that after the catheter is removed, these patients usually come back with a 3-way catheter. When it is removed, they should expect, and it's not unusual, that they would have dribbling and leakage around the catheter once it's removed. And it will subside in time. No, they're not going to be left with this forever. It will subside in time. Okay, let's go on. We'll we finished prostatic hypertrophy. Let's talk about acute and chronic renal failure. We'll talk about assessment of acute and chronic renal failure. With renal failure, there are several phases the body goes through, and the first phase is called the oliguric phase. During this phase of renal failure, the patient's output decreases. Usually their output will be less than 400 cc's per day. They will experience hypertension. They will have anemia. They may have symptoms of congestive heart failure, the pulmonary edema, shortness of breath, peripheral edema. They may become confused during this time. So safety issues are very important. And you will see an increase in you will see an increase in potassium, calcium, sodium. The BUN will increase, as will the creatinine. Let's take a look at the next phase. After the oliguric phase, the patient will go through the diuretic phase. During this time, you'll see that the patient is diuresing. Their output will be between 4 and 5 liters per day. Now remember, normal output is around 1,500 cc's per day. So this person will spend a substantial part of their day in the bathroom. Their BUN during this time will increase. Sodium, potassium will be lost in the urine, so they will go down. And there is increased mental and physical ability. So I mean, they feel better, and they're less confused, they're a little bit sharper, and they're able to have better abilities. Okay, let's talk about the different types of causes. There are 3 causes of acute and chronic renal failure. The first cause is what we consider pre-renal. What that means is there is a reduce in blood volume to the kidneys that has caused this renal failure. So it's pre-renal, it's outside of the kidneys, or pre-kidney issues. The second type or cause of acute and chronic renal failure is renal, meaning these are things that actually damage the kidney. These are nephrotoxic medications or drugs. Many of your antibiotics are nephrotoxic. Also, glomerulonephritis can damage the kidney such that the patient develops acute or chronic renal failure. So these are renal issues. The third cause of acute or chronic renal failure are called post-renal issues. These are obstructions somewhere along the line. So you have pre-renal causes, renal causes, and post-renal causes. Let's talk about what the implementation is, or the nursing responsibilities for a client with acute and chronic renal failure. We'll talk about what you do during the low output stage. During this time, you will limit fluids, and they will use K-oxalate. Remember, K-oxalate is used to decrease the potassium level. It is known as a cation exchange resin. It exchanges potassium for something else that will not hurt the body. These patients also will undergo dialysis. Now, during the high output stage, we'll be able to give the patient fluids as needed, because remember, they're voiding 4 to 5 liters per day, so they can get rid of their excess fluid. They're allowed to have it. During this time, remember, the potassium goes down, so rather than exchanging out the potassium using K-oxalate, during the high output stage, we will give potassium replacement. And again, it has to be monitored very closely, and the patient will continue on dialysis. Let's take a look at some of the other implementations we do for patients with acute and chronic renal failure. Well, these patients, it goes without saying, should be on intake and output. We will be weighing them daily. Same clothes, same time, same scale. We'll be monitoring their electrolytes, especially sodium, potassium, calcium. These patients should be on bed rest in the acute phase, and many times they will be receiving IV fluids. Now, we talked a minute ago, we said one of the treatments for acute and chronic renal failure is dialysis. Let's talk about dialysis. Okay. With dialysis, there's hemodialysis and peritoneal dialysis. Let's talk first about hemodialysis. What are the nursing responsibilities for a client with hemodialysis? it's important that you know to check for the thrill and listen for the bruit, which is spelled B-R-U-I-T. Now, it's hard for some students to remember which is the thrill, which is the bruit. If you remember that you feel thrilled, you'll keep it separate. So you feel for a thrill, you palpate or feel for it, and you auscultate or listen for the bruit. And this should be done every 8 hours. Another important consideration is you don't want to use the extremity to assess the patient's blood pressure, to obtain any blood samples, anything such as that. The patient should also be taught not to wear, if it's a woman, to wear her purse on that shoulder or carry it in that arm. That side of the body should be protected. Also, we want to monitor the patient for hemorrhage to make sure that nothing happens to that shunt. Now, a couple of complications of hemodialysis, and one we've just talked about, and that's hemorrhage. Other complications of hemodialysis that can occur are dizziness, muscle cramps, air embolism, and dysrhythmias. Let's go on now, and we're going to talk about peritoneal dialysis. With peritoneal dialysis, some of the nursing responsibilities are you will weigh the patient before and after treatment. And you would expect them to weigh more before treatment than after treatment, because peritoneal dialysis uses the peritoneal cavity to pull off excess fluid and to reestablish normal electrolyte balance. You want to monitor the patient's blood pressure. You want to monitor for breath sounds. And again, because this is an invasive procedure, you want to use sterile technique. Now let's talk about the different types of peritoneal dialysis that can be used. The first type is called CAPD, or continuous ambulatory peritoneal dialysis. This is where the patient or the client self-dialyzes 7 days a week for 24 hours a day. What they do here is the solution is warmed with a heating pad. It is instilled into the peritoneal cavity. The dwell time, meaning the time that it stays in the peritoneal cavity, is 4 to 8 hours. The tubing is then disconnected, the bag is rolled up, and it is worn under their clothing, and this client goes about their daily activity. After the dwell time, which is 4 to 8 hours, they unroll the bag, put the tubing down, and drain the peritoneal cavity back into the bag. Then the bag is changed and the process is repeated. Again, this self-dialysis takes place 7 days a week, 24 hours a day, and the patient controls it. Okay, let's take a look at the next type of dialysis. This is automated dialysis. Automated dialysis, in this case you use a machine with a warming chamber. The times of both dwell and drainage are set, as are the volumes. Usually there is a 30-minute exchange time, 10 minutes for the infusion of the solution, 10 minutes for the dwell time, 10 minutes for the outflow. And this is performed for like an 8 to 10 hour period using this machine. And again, it's an automated type of procedure, which is why they call it automated peritoneal dialysis. Let's take a look at another type of dialysis. This is called intermittent. Intermittent dialysis can either be automated or manual. Intermittent dialysis is performed 4 days a week for about 10 hours a day. And let's take a look at another type, which is continuous. Continuous peritoneal dialysis is when the patient or the client uses an automated machine at night. What they do is there's an exchange done at night. It's left in place during the day, and then that night, again, the exchange takes place. The person hooks themselves up to the machine so the exchange, the dwell time and all, can take place. Okay, so that's something that can be done for someone with chronic or acute renal failure. Let's talk about what is done for patients with chronic renal failure, and that's a renal transplant. In this case, it's important for you to know, and again, frequently tested, is the kidney with the kidney transplant is not put in where the removed kidney was. It is inserted on the opposite side of the body in the iliac fossa. Patients that undergo renal transplants will be put on immunosuppressive drugs for the rest of their life. This is to prevent rejection. Patients with renal transplants, it's imperative that we monitor their intake and output and their daily weight. If they begin to gain weight, it's not that they're getting fat, it is that they are retaining fluids. Now let's talk a little bit about the type of complications that can occur with renal transplants. First one is hemorrhage. Second one is rejection. And if a client is undergoing rejection, the type of things you will see are oliguria, which is a decrease in urinary output. The patient will experience edema. They will have fever or an elevated temperature. They will become hypertensive, meaning the blood pressure will go up. They will begin to gain weight, and they may complain of tenderness over the site of the kidney. Again, remember where the kidney is. It's on the opposite side of the body in the iliac fossa. And another complication of renal transplants are infections. So it's important that we use sterile technique whenever we're dealing with this patient and don't expose them to situations where infection could be obtained. This concludes our discussion of Physiological Integrity 1, Basic Care and Comfort. Thank you.